ಸ್ನೇಹಿತರೆ, ಇಂದಿನ ವಿಶೇಷ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ನಿಮಗೆಲ್ಲ ಆತ್ಮೀಯ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತೇನೆ. ಸರ್ಜಿಕಲ್ ಸೊಸೈಟಿ ಬೆಂಗಳೂರಿನ 50ನೇ ವರ್ಷದ ಆಚರಣೆಯಲ್ಲಿ ಗೋಖಲೆ ಸಂಸ್ಥೆಯ ಸಹಯೋಗದೊಂದಿಗೆ ಸರ್ಜನ್ಸ್ ಫಾರ್ ಸಿಟಿಸನ್ಸ್ ಎನ್ನುವ ಅಭಿಯಾನವನ್ನು ಆಯೋಜನೆ ಮಾಡಲಾಗಿದೆ. ಇದರ ಸಲುವಾಗಿ ವಿಶೇಷ ತಿಳುವಳಿಕೆಯನ್ನು ಕೊಡತಕ್ಕಂತಹ ಅಭಿಯಾನ ಇದಾಗಿದ್ದು, ಒಟ್ಟು 5 ದಿವಸದ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಇಂದು ನಾವು 2ನೇ ದಿವಸ ಇಲ್ಲಿ ಸೇರಿದ್ದೇವೆ. ಇಂದು ಜಾಂಡೀಸ್ ಮತ್ತು ಗಾಲ್ ಬ್ಲ್ಯಾಡರ್ ಬಗ್ಗೆ ನಮಗೆ ಹೆಚ್ಚಿನ ತಿಳುವಳಿಕೆಯನ್ನು ಕೊಡಲಿಕ್ಕೆ ನಮ್ಮೊಟ್ಟಿಗೆ ಡಾಕ್ಟರ್ ರವಿಶಂಕರ್ HR, ಡಾಕ್ಟರ್ ನಿರಂಜನ್, ಡಾಕ್ಟರ್ ರಾಘವೇಂದ್ರ ಬಾಬು ಅವರು ನಮ್ಮೊಟ್ಟಿಗಿದ್ದಾರೆ. ಅವರೆಲ್ಲರಿಗೂ ಕೂಡ ತಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ, ಸಂಸ್ಥೆಯ ಪರವಾಗಿ ಆತ್ಮೀಯವಾದಂತಹ ಸ್ವಾಗತವನ್ನು ಕೋರಿ ಇಂದಿನ ಕಾರ್ಯಕ್ರಮವನ್ನು ಆರಂಭಿಸ್ತಾ ಇದ್ದೇವೆ. ಮೊದಲಿಗೆ ಜಾಂಡೀಸ್ ಮತ್ತು ಗಾಲ್ ಬ್ಲ್ಯಾಡರ್ ಬಗ್ಗೆ ಒಂದು ಸಣ್ಣ ಪ್ರೆಸೆಂಟೇಷನ್ ಕೊಡ್ತಾರೆ. ಅದಾದ ನಂತರ ಇದಕ್ಕೆ ಸಂಬಂಧಿಸಿದಂತೆ ಪ್ರಶ್ನೋತ್ತರಕ್ಕೆ ಅವಕಾಶ ಇರುತ್ತೆ. ದಯವಿಟ್ಟು ಎಲ್ಲರೂ ಕೂಡ ನೇರ ಒಂದು ರೀತಿಯ ಸಂವಾದಕ್ಕೆ ಇಳಿಯದೆ ಚುಟುಕಾಗಿ ಪ್ರಶ್ನೆಯನ್ನು ಕೇಳಿ ಮತ್ತೊಬ್ಬರಿಗೂ ಕೂಡ ಪ್ರಶ್ನೆ ಕೇಳಲಿಕ್ಕೆ ಅವಕಾಶ ಮಾಡಿಕೊಡಿ ಅಂತ ಪ್ರಾರ್ಥನೆ ಮಾಡ್ತೇನೆ. ಇದೀಗ ಜಾಂಡೀಸ್ ಮತ್ತು ಗಾಲ್ ಬ್ಲ್ಯಾಡರ್ ವಿಚಾರವಾಗಿ ಪ್ರೆಸೆಂಟೇಷನನ್ನು ನೀಡಬೇಕು ಅಂತ ಡಾಕ್ಟರ್ಗಳಲ್ಲಿ ಪ್ರಾರ್ಥನೆ ಮಾಡ್ತೇನೆ.
ಸರ್, ಇದು ಇನ್ನೊಂದು ಪ್ರೆಸೆಂಟೇಷನ್ ಲಿವರಿಂದ ಅಲ್ಲ ಅದೇ ಇದು ಅವರು ಇದು ಮಾಡ್ತಾರೆ, ರಾಘವೇಂದ್ರ ಬಾಬು ಅವ್ರದ್ದು. ನೆಕ್ಸ್ಟ್ ಇನ್ನೊಂದು ಪ್ರೆಸೆಂಟೇಷನ್
ಇದು ಲಿವರ್ ಅಲ್ವಾ ಸರ್?
ಅದು ಲಿವರ್. ಇದು ಇನ್ನೊಂದು ಅದೇ ಕರೆಕ್ಟ್, ದಟ್ಸ್ ಒನ್.
ಎಸ್, ಓಕೆ. ಇದರಲ್ಲೂ ಮಾಡ್ಕೊ.
ಓಕೆ.
ಇದರಲ್ಲಿ ಮುಂದಕ್ಕೆ ಹೋಗುತ್ತೆ.
ಓಕೆ.
ಇದು ಲೈಟ್.
ಓಕೆ. ಎಲ್ಲರಿಗೂ ಆತ್ಮೀಯವಾದ ಸುಸ್ವಾಗತ ಹಾಗೂ ನನ್ನ ಅಭಿನಂದನೆಗಳು. ಮೊಟ್ಟ ಮೊದಲಿಗೆ ಸರ್ಜಿಕಲ್ ಸೊಸೈಟಿ ಆಫ್ ಬೆಂಗಳೂರಿನ ಅಧ್ಯಕ್ಷರಾದ ಶ್ರೀ ರಾಜಶೇಖರ್ ಜಾಕ ಅವರೇ, ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಮುನಿರೆಡ್ಡಿ ಅವರೇ, ನನ್ನ ಗುರುಗಳಾದ ಡಾಕ್ಟರ್ ಲಕ್ಷ್ಮಣ್, ನನ್ನ ಸಹೋದ್ಯೋಗಿ ಡಾಕ್ಟರ್ ನಿರಂಜನ್, ಹಾಗೂ ಇಲ್ಲಿ ನೆರೆದಿರುವ ಎಲ್ಲ ಸಭಿಕರಿಗೆ ನನ್ನ ವಂದನೆಗಳು, ನಮಸ್ಕಾರಗಳು. ಸರ್ಜಿಕಲ್ ಸೊಸೈಟಿ ಆಫ್ ಬೆಂಗಳೂರು ಅವರು ನನಗೆ ಈ ಅವಕಾಶ ಕೊಟ್ಟಿರೋದಕ್ಕೆ ಅವರಿಗೆ ಬಹಳ ಆಭಾರಿಯಾಗಿದ್ದೇನೆ. ಹಾಗೂ ಗೋಖಲೆ ಸಂಸ್ಥೆ ಕೂಡ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮವನ್ನು ಆಯೋಜಿಸಿ ನಮಗೆ ಜನಸ್ಪಂದನ, ಜನರೊಂದಿಗೆ ಜನರೊಂದಿಗೆ ವಾದ ವಿವಾದಗಳಲ್ಲಿ ಹಾಗೂ ಸಂವಾದದಲ್ಲಿ ನಮ್ಮ ಪಾಯಿಂಟ್ ಆಫ್ ವ್ಯೂನ ಅವರಿಗೆ ಹೇಳಿ ಅವರ ಪ್ರಶ್ನೆಗಳನ್ನು ತಗೊಳ್ಳುವಂತಹ ಒಂದು ಸುವರ್ಣಾವಕಾಶ ಇದು. ಸೊ ಅದಕ್ಕೂ ಗೋಖಲೆ ಸಂಸ್ಥೆಗೂ ನಾನು ಬಹಳ ಆಭಾರಿಯಾಗಿದ್ದೇನೆ. ದ ಸರ್ಜಿಕಲ್ ಸೊಸೈಟಿ ಆಫ್ ಬ್ಯಾಂಗ್ಳೂರ್ ಈಸ್ ಡೂಯಿಂಗ್ ಎ ಲಾಟ್ ಆಫ್ ಗುಡ್ ವರ್ಕ್ ಇನ್ ಟರ್ಮ್ಸ್ ಆಫ್ reaching out to the public and making sure we are not just there to treat patients, but we are also there to involve in public activities. And also it is important to make people aware of what our work entails and what are the common problems that people face and what do we do to deal with them. So, I am Dr. Ravishankar. I am head of the Department of Surgery at Sagar Hospital. I have come back from England in 2007-8. I was a consultant colorectal and laparoscopic surgeon in Manchester before that. Dr. Niranjan is a consultant laparoscopic and gastrointestinal surgeon at Sagar Hospital. Proudly, he was our student who was graduated to become a consultant, and a very good one at that. And Dr. Raghavendra Babu, who will follow me in the lecture, is a gastrointestinal and hepatobiliary surgeon at Sparsh Hospital, and he will follow my lecture. So today I am going to take a bird's eye view of the problem of jaundice and gallbladder stones, which is very common. The liver diseases part of it will be dealt with by Dr. Raghavendra Babu. So, just coming to the definition of what is jaundice. Jaundice is yellowish, kamale anta kannadadalli karitare, yellowish discoloration of the skin, whites of the eyes and body fluids. So, usually the patient themselves may not notice the jaundice. Many times it is the family, friends and relatives who will tell them, your eyes are yellow. Occasionally, if they watch their urination, they may find that the urine is very high colored and the stools are pale colored. So that may bring it to notice. But then there are so many other, I will come to the symptomatology later. There are two broad classifications of jaundice. One is what is called as medical jaundice, and the other one is a surgical jaundice. So I'll just enumerate the causes for medical jaundice and then go on to be more detailed on the surgical part of it, because I am a surgeon and that is what we do. So the first common thing that we all notice is alcohol. So alcoholic liver disease, which may you can get jaundice even in the acute phase. If somebody goes on a binge drinking, they may develop acute severe alcoholic hepatitis, and there is swelling of the liver. And when there is swelling of the liver, the biliary canaliculi, or the canals which bring the bile or pitta from the liver onto the intestines, the small canaliculi get blocked because of the swelling of the liver, and then develop jaundice at that time. Or there is destruction of liver cell, and that can also cause jaundice. Later, as the person continues to drink significantly, the liver goes into change called cirrhosis, and that can cause jaundice also. So alcohol is one of the most important causes. Second most important cause is viral infections like hepatitis A, B, C, D and E. Most important ones are obviously B and C, but the others are also can cause jaundice. Then you have a lot of congenital causes, which I don't think you need to worry about. Metabolic disorders can cause jaundice. Autoimmune, that is the body's own immunity, revolts against us, and that can cause jaundice. Drugs like paracetamol. Paracetamol is taken, in plenty by many people, thinking that it's harmless, but it can cause severe acute hepatic liver failure and jaundice. So you have to be careful about taking too much of paracetamol. And then some of the poisonous mushrooms, anti-tuberculosis drugs, they can all cause liver destruction and damage. Pregnancy also is an important cause for jaundice because of the swelling of the liver and the canaliculi, and that can cause. And then there is a condition which is now becoming very common in the last 10 or 15 years, is coming to public view, that is called non-alcoholic steatohepatitis or non-alcoholic fatty liver disease. So whenever you go for an ultrasound scan, whether it is a planned ultrasound scan or if for symptoms, say your own GP or your physician advises you to have a scan, the ultrasound machines are so good these days that even a small amount of fat in the liver is seen as a fatty liver. So, and this fatty liver, a proportion of them will go on to develop, in the fatty liver becomes more and more, and the liver becomes stiff and ultimately undergoes a transformation called cryptogenic cirrhosis, and that can also again cause jaundice. And there are a lot of bleeding disorders where the RBCs, lies in the body. They undergo destruction and they release bilirubin into the system, and that can cause jaundice. So these are, there are still probably an exhaustive list of this, but for public consumption, if you know this much, it's more than enough. So these are all the causes for jaundice. Now coming to surgical jaundice. So this is the crux of our talk. The commonest cause for surgical jaundice is gallstones or stones in the gallbladder. So that is the most common cause for jaundice. Then you have again pancreatitis. It's a condition. The two most important causes for pancreatitis is one is alcohol and second is gallstones. So the gallstones, when they move down from the gallbladder into the biliary ductal system, it can block the flow of the bile, and that causes jaundice. So that is so that is one of the commonest causes. And then the pancreatic cancer. See, again, I think this is a very even after so many years of advances, pancreatic cancer still remains a huge challenge to the surgeons, because majority of the patients do not have any symptoms, and by the time they get symptoms in the form of pain that radiates to the back, and then jaundice, loss of weight, loss of appetite, and feeling of weakness, by the time the patient is investigated, majority of these pancreatic cancers would have reached stage 3 or 4, where it is very difficult to treat them with an intention to cure. So that again, pancreatic cancer is one of the commonest causes for jaundice. As I said, gallbladder and bile duct cancers also can cause jaundice in the later stage. Bile duct cancers in quite early, gallbladder cancer itself later in the process of the disease, primary liver cancer and secondary liver cancer. So liver is one of the commonest organs affected by spread of disease from elsewhere. For example, breast, colon and rectal cancers, stomach cancers. These are the common ones which can spread to liver, and that can cause jaundice. And a condition called lymphoma, which is a blood and reticuloendothelial system related cancer, which again can cause involvement of the liver, also involvement of the lymph nodes in the base of the liver, pressing on the bile duct and causing jaundice. And some of the other cancers which spread to the liver can also spread to the lymph glands, which are at the base of the liver, what we call as the hilum, and there it can press on the bile duct and cause cancer, jaundice. So coming to the symptomatology, what will the patients feel and see? As I said, a commonest thing is yellowish discoloration of the eyes and the skin. The eyes, the white of the eye, what we call as the sclera medically, that is the commonest. It has got lot of elastin fibers, and hence it is got the affinity for bilirubin, and that becomes yellow. And usually the normal bilirubin is between 0.4 to 1 or even just slightly less than that. So clinically obvious jaundice will be above the level of 2 mg% of bilirubin. And then you have itching all over the body, and then nausea, vomiting. These are again common symptoms. Then when you pass urine, you see high colored urine and your stools will be pale. There will be, see the difference between, we always say, these things can be interchangeable, but the difference between jaundice that is due to gallbladder stones and jaundice that is due to pancreatic and other cancers is the pain. So in gallstone related disease, at least at the first episode, you will always have severe pain. But with pancreatic cancer, the pain comes later, where the infiltration of the nervous system, what we call the celiac plexus, and the nerves in the back of the abdomen, then you get severe pain. But pain is quite a late symptom in pancreatic cancer. So painless jaundice is much more of a feature with malignancy. Jaundice with pain is usually associated with gallbladder stones. Then there is loss of appetite, loss of weight, and loss of weight is usually with malignancies, or even with severe gallstone disease and pancreatitis, you can get weight loss, but that is much less compared to the malignancy or the cancer related weight loss. And when you have stones that are stuck at the neck of the gallbladder, you can develop a condition called infection of the acute infection of the gallbladder, what we call as acute cholecystitis, that can cause fever with chills. But more importantly, if the stone migrates into the bile duct, you get obstructive jaundice with the severe abdominal pain and fever and chills and rigors. So that is one of the commonest conditions where you get fever with chills and rigors. So that is called cholangitis, or infection of the biliary ductal system. Then you have, general weakness and tiredness because of the, more again in pancreatic, and other related cancers, more than compared to the gallstones. Then you can have conditions where, ankylosing spondylitis, rheumatoid arthritis, and other what we call as autoimmune conditions, where you can get involvement of the liver, especially with rheumatoid arthritis, with the inflammatory bowel disease. You can get a condition called sclerosing cholangitis, and also gallbladder stones itself is also quite common amongst these people. And then you also have eye disorders, iritis, iridocyclitis, and things like uveitis. These are common conditions associated with jaundice. Okay, now what should you do when you get either of these symptoms or all of these symptoms? Kindly consult your local general practitioner or a family physician or a liver specialist or physician, surgeon. We will be very happy to see you, and gastroenterologist. Do not, thinking that this will all go away. Please do not self-medicate or ignore these symptoms, because some of them may be innocuous, but some of them can be dangerous. Please do not ignore these symptoms. Jaundice doesn't happen, for no reason. So jaundice is an important sign. If you notice it, please consult somebody. And then there is this fad going to Ayurveda, homeopathy, and then, till for a long time before the horse has bolted. And then you come to the right person, and by that time, many times we will not be able to do anything. See, I have nothing against the other systems, but please consult the above said people, make a diagnosis, find out what exactly is wrong with you. And then, with consultation with yourself and the person treating and the family, you can then decide. If you are not happy, if you want to go other systems, that is your choice. But please do not think that if you go to the Ayurveda and they will, somehow miraculously cure you. First of all, they have to tell you what exactly is wrong. Just saying you have pitta, vata, or whatever, may not be sufficient. We need to know the exact reason why you have developed jaundice. So please consult a physician or a gastroenterologist or a surgeon. Get to know the diagnosis, then you can decide what treatment you need to have. Okay, so as I said, the pain is the most important symptom in the gallstones. I am now coming to gallstone disease. I will leave it to Raghavendra Babu to talk about other conditions. The pain is mainly in the right upper quadrant, or just below the rib cage on the right side, and in the midline abdomen. The pain can radiate to the shoulder tip or to the back. It can also radiate to the lower chest. See, there is an important warning here. No patient has died because of gastric trouble or gallstone disease, especially early. They can die later if they develop complications. But the most important thing is, do not again presume that you have gastric trouble, because one of the most important conditions which will mimic these symptoms is a heart attack. So please make sure you see a physician, ensure that you have no problem with the heart, and then we will deal with the gastric or whatever trouble that is. But do not presume, because people can die out of heart attack if it is ignored. Most people won't die because of gastritis or gastric trouble, as most people call it, or gallstone disease, especially early in the disease. So please ensure that you see a physician, and ensure that they have ruled out any cardiac causes for the symptoms, because many times what we call as the inferior wall MI can present exactly like gastritis or gallbladder disease. So please do not ignore that. Then what commonly people call as gastric symptoms, dyspepsia, that is heartburn, excessive burping, and then these are things. See, there are two conditions which cause this plethora of symptoms, what people commonly club or label as gastric symptoms. One is due to hyperacidity, other one is due to gallbladder stones. But please remember that it is very rare, till again very late in the disease, that with hyperacidity you will get severe pain. You may get burning, especially when you have empty stomach. You may get burning symptoms, but you will never get severe pain. If you get severe pain, it is usually due to gallbladder stones, gallstones. Please investigate the matter before you take any treatment. So please, consult a physician or a surgeon for that. Then you can have, if the gallbladder stones is more complicated, you can get fever with chills. You can also get postprandial fullness, bloating of the abdomen, and excessive belching. And then, again, if the gallbladder disease becomes more complicated, you can develop pain with fever and jaundice. So what are the common causes when patients come to us? The common question they ask is, why do we form gallbladder stones? The simple and plain answer to that is, we really don't know. There are several postulates and theories, but I will just enlist the possible associations with the gallstones. One of the commonest thing is pregnancy. And, many times I tell, young women who come with consultation during pregnancy or immediately following, I say it is not your fault. If at all you have to blame anybody, blame your child. Because of the child you have developed jaundice. Why is that? Because during pregnancy the levels of cholesterol goes up. That is to maintain the hormonal levels of the women so as to maintain the pregnancy. And also cholesterol is an important ingredient in the nerve sheath for the development of brain and the nerve cells and the sheaths of the nerve. So there is excessive demand for cholesterol, and hence cholesterol is manufactured in the body to a great extent, and majority of that is secreted into gallbladder, and hence there is what we call as the cholesterol rich bile, which is called lithogenic bile. That is, it forms stones. Initially it will form the sand like granules, and then it become what is called as sludge, and then later it becomes gallbladder stones. So that is one of the common. Pregnancy is definitely associated with gallstones. Then again, high cholesterol levels, hypercholesterolemia and hyperlipoproteinemia. These two are definitely known to cause gallstones. Diabetes again is commonly associated with gallstones. And another thing please remember is, whenever, I'll come to the indications for surgery, but whenever patients who have diabetes and have gallstones, we are more inclined to advising them surgery, because there are specific complications with relation to diabetes which can be quite lethal. So when we advise surgery, it is not because we want to operate or we want to make money, and no vested interest there. Patients, even though they are majority of them are symptomatic, but they will ascribe their symptoms to gastric trouble, but it is usually due to gallbladder stones. But if they have a combination of gallstones and diabetes, we would usually recommend surgery, because there are conditions where empyema of the pus in the gallbladder, emphysematous cholecystitis, where there is air in the wall of the gallbladder, and these kind of severe conditions which has a mortality upwards 25 to 70% in emphysematous cholecystitis. So we recommend surgery, because when there is no complication, there is a one-day hospital or a day case admission, and by and large you get the gallbladder removed and you will have no problems for the rest of your life. But if you develop these complications, you may end up in ICU needing ventilator support, inotropy, that is blood pressure support, dialysis sometimes, and many times there is unfortunately mortality or death also. So when we advise surgery in diabetes, it is for that reason. Next is obesity. Again, obesity is one of the causes for gallstones. In addition, it can also be a complication where surgery will be quite difficult in obesity. Then there are conditions called Crohn's disease, and sometimes even tuberculosis is common in India, where there is involvement of the terminal portion of the small intestine. Liver is a fantastic organ in the body, and before anybody invented recycling, the body has been doing this for a long time. So the bile that is secreted by liver is absorbed back in the terminal portion of the intestine, and we call this as enterohepatic circulation, recycling of the bile. So the same bile gets recycled. And when the terminal portion of the liver is resected for disease, or if the disease is so severe, the absorptive ability of the area of the small intestine in that area becomes less because of the inflammation, then there is high chance of development of gallstones. So what are we going to do when you come to us with these symptoms, the symptoms that I have listed before? One is, we do a thorough physical examination. We look at jaundice, we look at whether you have lost weight, have you got anemia and other signs of liver failure, if there are any. when we examine the legs to see if there is any swelling, to see if your protein status is low, if you are low protein is one which hypoproteinemia, and then we examine the abdomen to see if there is any mass palpable. Gallbladder, is it palpable and is it tender? Is the liver palpable? Is there any fluid in the abdomen? And all these things we examine you in detail. Then we ask for some blood tests, especially the total blood count to see if there is infection on board. Then we look at liver function tests, which will tell us whether this jaundice is medical or surgical. I don't need to go into details of that because we will be able to interpret that for you. Then we do a test called prothrombin time and international normalized ratio, PTINR, to see if the liver is functioning normally. That is one of the indications of liver function. Then we go for and urine test. Again, urine will see presence of urobilinogen, and then we will be able to say whether this is a medical or a surgical jaundice. Then we go into the ultrasound of the abdomen. For gallbladder stones, ultrasound scan is the gold standard, and about 98 to 99% of all gallbladder stones are picked up by the ultrasound scan. It will also give us information about the liver, whether there is any dilatation of the biliary ductal system inside the liver, the diameter of the common bile duct, which is the main duct that runs from the liver into the intestine, and it will tell us a lot of information. It will also tell us whether there is evidence of pancreatitis. The only problem with the ultrasound is because ultrasound waves do not traverse through air, the terminal portion of the bile duct goes behind and under the first part of the intestine called duodenum. So when that happens, so if there are stones or narrowing or what we call a stricture in that area, the ultrasound may not be able to pick it up. So hence we then, if there is evidence in the liver function test that there is obstructive jaundice, if the ultrasound suggests there is bile duct dilatation, we then go for a investigation called MRCP, which is magnetic resonance cholangiopancreatography. Again, don't get worried about these terminologies. It is to image the liver and the biliary system, both intra and extrahepatic. We look at we'll get a roadmap of what the bile duct looks like. Are there any stones or sludge blocking the bile duct? Is the ductal system dilated? Is there any narrowing of the terminal portion of the bile duct? A lot of information is gleaned. See, the jaundice can happen, this gallstone disease can happen from young adults till late in the thing. So as we near the elderly age group, there can be malignancy. Gallstones may be there, but they are just red herrings. They may be sitting there, but there may be other things like sometimes gallbladder cancer, bile duct cancer, pancreatic head cancer. So these are things. So MRCP will give us an idea about all these things. Sometimes when we are not sure of the diagnosis, we do get a CT scan which can give us more information, especially with the pancreatic lesions and pancreatic head. See, just mere presence of gallstones does not mean all your symptoms are due to gallstones. So this is why artificial intelligence or WhatsApp University, as many of you consult, will not give you, because it may give you knowledge, but it won't give you wisdom. So we have to, as physicians and surgeons, we have to look at your symptoms subjectively, examine you objectively, and then marry that with all the investigations we have to then ascertain, are these symptoms due to gallstones or due to something else. So this is the process of elimination, and these things which we do, and we put in a lot of effort to do that. So that is why it is important. Sometimes you get a CT scan, and then endoscopy if required, ERCP if at all there is ductal stones and stricture of the duct, where we may have to do what we call as a sphincterotomy, and cut the sphincter and release the bile which will be backed up or obstructed the biliary system. We'll put a balloon and remove the stones, and sometimes we'll dilate the stricture or narrowing in the bile duct, and then put a stent to facilitate free flow of the bile from the liver through the bile duct into the intestine. This has to be done before we do the gallbladder surgery, because if a system that is obstructed in high pressure, if we try to do a cholecystectomy, then the clips that we put to secure the cystic duct or the duct from the gallbladder into the bile duct may blow out because of the high pressure. So which is why we have to first do the ERCP and deal with the stones in the bile duct. and then subsequently do the cholecystectomy. So there is a plethora of investigations. See, there is two-way things here. One is patients who come to us with symptoms, and we ask for some certain investigation, and patients say, this doctor is asking for too many investigations. I think he has got vested interest. He is making money through the diagnostic center. And then there is a second set of people who come with a big packet of investigations, and if you are trying to talk to them about their symptoms, they just show the packet to you and they expect you to see that first before examining. Both are wrong. So I would say we always, I think surgeons, see, medical community, though is a microcosm of society, there is a significant amount of principles and morals that we follow before we treat the patient. So please have that in mind. We never ask for investigations without its necessity, most of us. Okay, so, and the other thing is, if you come with a packet of investigations, we don't want to get biased by the findings that are there in the x-rays. We are not treating the x-rays of the patient, we are treating the patients. So that is why what we have to do is to first examine you, hear your story, develop a rapport with you, then look at the investigations, and then finally come to a conclusion as to what the problem is. Okay, now, so surgery for gallstones. So laparoscopic, or what we call as laser or keyhole surgery, that is the gold standard for surgery. And we have to remove, many people ask us this question, are you just going to remove the stones, or are you going to remove the gallbladder? See, the gallbladder is removed not because it contains stones, because it forms stones. So for example, if I today go in and just remove the stones, 6 months or a year later, they will develop further gallstones. So we can't keep on playing this game of going inside the abdomen, removing the stones and coming back. And for example, people ask, sir, is the gallbladder not necessary? It is necessary as long as it is functioning. So once the gallbladder forms stones, it is diseased and it is no longer functional. If you want proof for that, we can do what is called as scintigraphy, which will give us just like you get the ejection fraction of the heart, we can give you ejection fraction of the gallbladder, and most of the time when there are gallstones in the gallbladder, the ejection fraction will be very low and that gallbladder is not functioning. So we remove the gallbladder because it is not functioning. If you contrast this with the kidney, kidney is an essential organ and kidney stones are hard, gallbladder stones are like putty. And if you blast them with lithotripsy, the kidney stones can be blasted into small bits and that can be passed, but gallbladder stones cannot be done that. And then kidney is not at fault. It is the metabolic problems that causes stones in the kidney. Kidney is not at fault at all. But as far as gallbladder is concerned, gallbladder is at fault, and that is the reason why you form stones. So we have to remove the offending organ, which is the gallbladder. So that is why it is the procedure of choice. There is no role for non-operative treatment in patients who get symptoms which can later lead to complications. So we always, when we counsel the patients and take their informed consent, we will tell them why are we doing the surgery, what is the surgery, what does it entail. Then we also tell them what will happen to you if you don't undergo surgery. So what are the things that will happen is you will have severe cholecystitis or pus in the gallbladder. The gallbladder may rupture. The stone may pass into the bile duct and cause cholangitis or pancreatitis. And some of these things can be lethal, leading you to ICU stay and everything. So which is why there is no role for symptomatic gallstones to be treated without surgery. And sometimes asymptomatic gallstones can be managed conservatively in elderly people. For example, who is already 80, they undergo some scan for some other reason and find gallstones. We don't offer operation. We tell them, if these symptoms come, please come to us and then we will deal with it. So it is not necessary that we always advise surgery. And in patients who have, who are medically unfit with significant cardiorespiratory problems and other problems where the risk of surgery is very high, we don't operate on them. And then in women, in pregnancy, especially if they are asymptomatic. See, things have changed. Anesthetic expertise has improved so much that we operate in all the 3 trimesters, especially so in the 2nd trimester. If the patients have detected to be having gallstones and they are symptomatic with it. If they are not symptomatic, we can monitor them and wait till they finish the pregnancy and then operate on them. Okay, so what are the indications? As I told, symptomatic gallbladder stone disease. acute cholecystitis or acute infection, chronic infection. There is also condition of acute on chronic cholecystitis or acute on chronic infection. When patients have obstructive jaundice, it's stones in the bile duct, and pancreatitis. If there is pus in the gallbladder, rupture of the gallbladder, or gangrene of the gallbladder. All of these are indications. Then and symptomatic and complicated gallstones in pregnancy. And then there is a condition, as I showed, hemolytic anemia, where the body's own red blood cells rupture and release significant amount of bilirubin into the system, causing formation of pigment stones in the gallbladder, and they have to be operated. And usually as part of other surgeries like bariatric surgery and cancer surgery, we remove the gallbladder. And then what does the post-operative recovery entail? Usually there is minimal pain on a scale of 0 to 10. Usually it's 1 or 2, and then there will be nausea and vomiting, mainly due to the anesthetic that you have received, sometimes sore throat because of the intubation, and then usually 1 dose of antibiotic is given to cover the period of surgery, half an hour to 1 hour before surgery. Then usually it's a day case or 1 day admission in the hospital. Then there will be quick return to normal activities and your work, and then there is no restriction. Please listen to this. There is no restriction in terms of diet, activity, bath, driving, walking, exercises, and travel. You can do all of these things without any problem. Okay, so what are the problems and complications? You can have bleeding during surgery. I'll show you a picture, then you will realize that. So you will get shoulder tip pain and back pain, which will last usually 1 or 2, 3 days maximum. You may develop jaundice post-operatively if there are stones in the biliary duct which have been missed, because many of the investigations only are sensitive to 93 to 95%. So there is a 5 to 7% chance that there may be stones that are missed, especially if they are radiolucent. If they are radio opaque, they will be picked up. Lucent stones may be missed, especially pigment stones. So you may develop jaundice later. Conversion to, see, normally if there are extremely skilled and very high volume centers, the conversion rate is about 1 to 2%. But a 5 to 10% conversion rate is acceptable in conversion to open surgery. Conversion is not a complication. It is done for your own benefit. If the anatomy of the biliary system is not clear, instead of cutting the bile duct or damaging the bile duct, it is better to open, get a better view, and do the operation. And sometimes there will be unexplained blood vessels and may bleed, and we may not be able to control it laparoscopically. We may have to convert. There are many reasons, but these are the 2 most common important reasons. But if we convert it, you should not construe that as inability of the surgeon or a complication. It is an accepted procedure. Whenever we take a consent for gallbladder surgery, we will always say laparoscopic stroke open cholecystectomy. That is because we never know. No investigations will give you the complete picture. Only when we go in, we will realize that. There are lots of other avenues which we do take before we convert, but sometimes it is inevitable. So that is one thing. Then you can develop, because gallbladder is just under the diaphragm, you can get chest infection, cough, collection. Where we have removed the gallbladder, you can get collection of bile, blood, and that may turn into pus that we will be able to drain. And then wound infection at the site of the ports where we have put it. Sometimes you can get bile leak from ducts that are invisible. They may be hair breadth like, and then they will leak bile, but they usually stop on their own. And then bile duct injury. This is the most dreaded complication which we all try to avoid. It is less than 0.3 to 0.445%, less than 0.5%. But still, it is a very life-changing event, and we do everything in our power to try and avoid bile duct injury. And pancreatitis post-operatively is another complication. So overall complication, all that I have listed is 1 to 2%, which is very, very good. And then the complications vary according to the comorbidity of the patient. Patients on blood thinners for cardiac conditions, chest problems, steroids, and then patients with liver and renal failure where there is decreased immunity. Then higher complication rates are seen in emergency procedures and acute presentations because of the severe inflammation and the non-clarity of the anatomy of that region, and in complicated biliary stone disease, and also higher in late presentations. Men are, women complain that men are difficult. In this particular thing, I agree with the women, because we always dread a 60, 70-year-old male with cholecystitis, because invariably it will be complicated. And because they are so stoical, they come very late in the course of the disease. Normally, according to the Japan, the guidelines for acute cholecystitis, maximum they say is up to 96 hours after the onset of symptoms, you can do laparoscopic cholecystectomy in the index admission, that is the first admission. But according to the skill levels of the surgeon, you may stretch that even up to a week. But the thing is, beyond that, what happens is the inflammation becomes so intense, bleeding is a major issue, and the clarity of the anatomy of that region also becomes a problem. Then you may develop an open cholecystectomy rates go up to 25% in acute presentations which have not settled on conservative treatment. So what are the common myths with the gallbladder? So people always come and say, we have 5 stones, now it has become 4, or it was 3 millimeters, it has now become 8 millimeters. None of these matters. Number and size do not matter to a large extent. So obviously, the thing is, what we have to realize is, the smaller the stones, the complication of obstructive jaundice, pancreatitis are higher, and bigger the stone, it getting impacted in the neck of the gallbladder and causing acute cholecystitis are higher. But the stone's number and this one size do not really matter. And can you not just remove as I've answered this question already, can you not just remove the gallstones and leave the gallbladder alone? Not possible, should not be done. And do you suffer from digestive problems after gallbladder has been removed? Again, not a problem. 5 lakh cholecystectomies are done in the United States every year. I think, that answers the question. Usually, I have never seen anybody having any major problem. There are this one called post-cholecystectomy syndrome, but that is a different thing. It's nothing to do with removing the gallbladder. It is the anatomy and the physiology of that region which causes the problem. And then you have to realize, I have told this before, surgeons do not advise surgery for personal or financial gains. No, we will only advise it for your good. And if the indication is right, see, you have to realize that legally we have no standing if we have done surgery when there are indications are not watertight. At first point we will fall. So why will anybody want to invite trouble? So, and we also have, contrary to popular conception, we always have the patient's best interest at heart when we advise anything. So please do not have that opinion. And second thing is, it's not a simple surgery. Ask any surgeon. Difficult gallbladder is one of the surgeries which challenges them the most and gives them sleepless nights. So it is not a simple surgery. Now I'll just go through some of the figures for your understanding. See, this is the gallbladder here, and you can see there is a significant amount of clockwork around it. See, this is the aorta, this is the inferior vena cava, portal vein, the main artery that runs from the aorta into the liver, that goes next to the gallbladder. And so there are a lot of important structures in and around that area. So there is potential for damage at every step of the surgery. So we have to identify and isolate this whole area correctly so that we are only cutting important structures that are leading to the gallbladder and not anything else. Okay, I'm just going to show you operative pictures of the cholecystectomy. So this is the bile duct, the common bile duct is there somewhere, and this is the duct called the cystic duct coming up to the gallbladder. So we start the dissection. This is called the posterior or back dissection of the back, and on the other side is the anterior dissection. So now we have, see the liver. So this, we have completely cleared this area. Now you can see the bile duct is there. This is the duct that is coming from the gallbladder. Probably this is the blood vessel that is supplying the gallbladder, which is called the cystic artery, cystic duct, common bile duct. So we have to demonstrate this triangle of safety. And till we have demonstrated that, we are not supposed to clip or cut anything. Last one, sir. So this is the completed procedure. You can see the gallbladder. We have put the clips across the cystic duct and the artery. We cut that and we remove the gallbladder. And this is the latest invention we have, which is called the indocyanine green infrared. This one, it is available with the same laparoscope. And you see here, you can see the cystic, common hepatic duct, common bile duct, the cystic duct. So if this anatomy is clear, then we can clip the cystic duct and the artery, and then remove the gallbladder. Thank you very much. I think I have covered the symptoms, the indications for surgery, the complications, and the do's and don'ts. Then we will take all the questions later. Now I invite Raghavendra Babu for his presentation.
liver ಅಲ್ವಾ ಸರ್?
Hello everyone, I'm Dr. Raghavendra. I'm a liver HPB surgeon. Today we'll be talking in brief, using common terminologies about liver diseases. I'll hopefully not take much of your time, and I'll take a lot of more questions probably. So liver, in brief, liver is a key organ, a very, very important organ. It's where almost all of the metabolic activity, the activity in our body takes place. In simple terms, this is not the overall functions of the liver. There are like thousands of them. Basically, it removes all the potential toxic waste that generates that gets generated in our body. It also is very important to generate something called bile, which has many functions. But the most important functions is about absorption of fat-soluble vitamins and fats inside our body. It also helps in fighting a lot of infections in our body. It also breaks down a lot of the contents that we consume, the nutrients that we consume, and stores it and utilizes it. So there are many functions of liver in our body. I think we'll just jump to the topic directly. I think this is something that we find the commonest questions from. Most people come to me with an ultrasound of a fatty liver. Sir, I have fatty liver, I have pain here, what should I do? So I'll just clear some myths about this fatty liver. Fatty liver, or it's in our medical terminology, we call it as a non-alcoholic fatty liver disease, is just build up of fat globules. It's just as the name suggests, it's just build up of fat globules inside the liver. And unfortunately, it is the most common liver disease worldwide. And fatty liver in itself is, really it's a benign condition. You really need not worry about it. It just stays with you until you're there, and it will really not harm for majority of individuals. But then in a small percentage of individuals who have fatty liver, fat can induce some inflammation inside your body, and that is a dangerous condition, and that is called as non-alcoholic steatohepatitis. That's the terminology. By the short term, we can call it as NASH. So fatty liver, a lot of us have fatty liver, really don't need to worry, but we need to worry only in a small percentage of individuals where fat induces inflammation. So that NASH is a dangerous condition which can lead on to liver failure, liver cancers, lot of other liver diseases. Why is this fatty liver? What are the causes of this fatty liver? Usually alcohol is the most important cause, but we are not really talking much about alcoholic liver disease today, because I think it's very simple how to avoid alcoholic liver disease. I think all of us know the answer: stop alcohol. So it's a very simple thing. Don't reuse alcohol, you'll not get alcoholic liver disease. Other things will come to now. What about this rest of the fatty liver? It's a lifestyle related disease. About 70% is obesity. Fatty livers are usually occur in obese individuals. It doesn't mean that lean and fit individuals don't need to have fatty liver. They can still have fatty liver, but majority is with obesity. But more importantly, diabetes is one of the leading causes for fatty liver. About 75% of individuals with significant fatty liver are also diabetic. It forms into the major syndrome X that we talk about, where people have diabetes, the cholesterol and will be high, fatty liver will be there. It's all a combination of diseases. They're all interlinked to one another. High levels of these bad cholesterols are also important in fatty livers, and some people who take certain medications like steroids for a long time can develop fatty liver. So the important question is how to differentiate between this normal simple fatty liver to a dangerous NASH. Fatty liver usually is found out by doing simple scans. using a simple ultrasound scan, CT scan or an MRI scan, any of these scans can give you fatty liver. But just to differentiate with these two using scans is not possible. We need to do some blood tests, some liver function tests. In liver function test, there are a lot of parameters in liver function test. I think all of us have once or in our life we have done liver function test. There are a lot of parameters. There is bilirubin, there is enzymes, SGOT, SGPT, ALT, AST, GGT. So a lot of parameters are there. So using these blood parameters, we can ascertain whether it's a simple fatty liver or a dangerous NASH. In a simple fatty liver, all these liver function tests will be normal. Whereas in a dangerous NASH, along with the fatty liver that you have, your liver enzymes will be elevated. Your liver function test will be altered. So this is a very simple way to differentiate the NASH from fatty liver. Obviously, there are a lot of other tests that we do, non-invasive fibro scans we do to know how stiff the liver is. To actually confirm NASH, the best test is biopsy, liver biopsy. But these are all some things that we will talk about in a later part of the equation. But yeah, as a simple thing to differentiate NASH and fatty liver, we can do a simple liver function test. Are there any symptoms of this fatty liver? Most people don't have any symptoms, and the symptoms that most people come to us with using some weird pain in the upper abdomen is really not due to fatty liver. Some people may get some fatigue and generalized weakness, but it is really, there is no particular symptoms of NASH. And I think this is a very important slide we need to understand about liver diseases. As you can see, as a healthy liver, usually a very soft, sharp liver, a healthy liver can turn into a fatty liver. The second picture there is fatty liver. The second picture here is the fatty liver. Healthy liver can turn into fatty liver because of alcohol or lifestyle habits. But I think one we need to remember is this is completely reversible. Completely reversible back to fatty liver, back to normal liver. And this fatty liver can turn into NASH. In a small amount of individuals, it can turn into NASH. But even here, it is completely reversible back to normal liver. But once, if we ignore this, and it progresses on, if the damages occur even more, if it progresses on to the last stage called liver cirrhosis, then it is in most circumstances not reversible. It's a permanent damage that is not reversible. Liver is one of the organs in our body which is the only organ in our body which can regenerate. You cut half of the liver in a month, it will grow back. So, but it can only take that much. After a certain point of time, it undergoes scarring called cirrhosis. At that last stage, it is not reversible. I think this is the most important sort of a thing that we need to remember from today. People come to me like, what should I do to this fatty liver? Generally, fatty liver, a normal benign fatty liver, does not require any treatment. Normal lifestyle modifications like eating healthy, activity is all that is necessary for it. Why should we take care about this fatty liver even though it will not cause any problems? Is because you don't know, you may be in this small percentage of individuals who will progress us on to NASH. So it is important to reverse it back to a normal liver. And coming to NASH, what are we treatment of NASH? I think consult a hepatologist or a physician, because I think treatment of NASH, you should not self-treat yourself. You should approach a doctor. Basically, doctor will tell you about a weight loss plan if you are overweight. If your blood sugars are high, that should be controlled. If your cholesterols are high, that should be controlled. For severe NASHs, we give some medications. Usually vitamin E is something that we give. A particular molecule of vitamin E is what we give to control it. And there are various other new medications that have come to treat NASH. But if there is NASH, that has to be taken seriously because it's reversible and treatable. A simple thing about alcoholic liver disease, still the most common liver disease which cause liver cirrhosis and liver failure in India. Alcohol causes the same oxidative damage to the liver cells, induces fat accumulation, fibrosis. Progression is also the same slide that I put. Even in alcoholic liver disease undergoes fatty liver, it's still reversible, but once it undergoes cirrhosis, it is not reversible. So coming to this liver failure, I think this is a thing that terminology that we often find ourselves. What is this liver failure? Why does this liver fail? I think the commonest causes are listed here. about 40%, I think majority right now is alcohol. But I think what is happening is this NASH, 25% is fast catching up. I think within the next decade, NASH will become the commonest liver disease to lead to liver failure. Cryptogenic is something that we don't know, causes that we don't know. There are some hepatitis infections which are totally preventable now. There is vaccines available to hepatitis B. I think now it is included in the national immunization schedule. Anybody who has not taken it, I strongly recommend you to take hepatitis B vaccines, because it is hepatitis B can be completely avoided using those vaccines. Some rare causes like metabolic liver diseases are all causes of liver failure. So coming to cirrhosis. So what is this cirrhosis? What is this last stage of liver disease called cirrhosis? In cirrhosis, liver cells completely die and form a scar. And this leads to a smooth, soft liver leads to a hard, scarred liver like this. This is a cirrhotic liver. Usually liver heals itself, as I told you, but when the damage is severe enough, it will not heal itself, it will form scars. And cirrhosis can lead to liver failure, it can lead to bleeding, blood in the vomiters, it can lead to liver cancers, it can lead to many different problems, and many of them will not have any proper treatment for it, because there is no proper medical treatment for it, and the only treatment finally when it progresses is a liver transplant. So what are the signs of this liver failure, where you should be sort of vigilant when liver failure is happening? Usually jaundice is one of the, one thing that we need to remember is that all of these signs that I am talking about happen in a late stage. None of these happen in an early stage. These stages happen only when about more than 80% of your liver is already damaged. So hopefully we should find out before that, we should avoid these liver diseases before that, and not lead on to these sort of symptoms. But these are the symptoms that can happen in a liver failure, where there can be jaundice, there can be forgetfulness, there can be confusion, there can be coma. Some people feel very tired, easy fatigability. People will lose their muscles, they'll become very weak. There can be itching, there can be poor blood clotting, there can be swelling of the abdomen with fluid inside, there can be blood in the vomiters or black colored stools. So these are the signs of liver failure, and we need to be vigilant about these signs. Briefly, how is the cirrhosis treated? We usually score this cirrhosis. We have a lot of scoring systems. It's beyond the purview of this talk. What are these scoring systems? Approach a liver doctor, liver physicians. They'll be able to tell you about what stages liver failure is in. Obviously, the most important thing is to prevent further damage. If you're an alcoholic, stopping alcohol, or if you have a viral disease, taking antiviral drugs, are some of the things that will stop the further damage. That is the most important thing. And somehow, even in that cirrhosis, there will be some healthy liver left. We'll see how to protect that healthy liver and lead on a normal life. That is something that can be done using different medications, try and protect. Even whatever medications we may use, we may not be fully successful in completely protecting those cells, but we can at least try. Treatment of the complications of cirrhosis, like there may be blood in the vomiters, we can put some bands to it and stop the blood in the vomiters. So those complications can be individually treated. Also, cirrhosis can lead on to liver cancer. So we do repeated scans to see if there is any development of cancers. And if it is detected at an early stage, we can treat it in a better way. So what we are doing is preventing or delaying the inevitable, where patients will go into a liver transplantation. So I think all of us agree, only about 1 to 2% of people who need, among the people who need transplantation, only about 1 to 2% of them undergo transplantation. Rest 98% won't really make it to transplantation. It can be many causes for it. It can be social help may not be there. It can be lack of donors. It can be financial reasons. There can be many different reasons for it. In India, almost 98% of people who need transplantation, liver transplantation, unfortunately don't get liver transplantation. But right now, for an advanced cirrhosis where patients are sick, liver transplantation is the only treatment. So it's a life-saving procedure, and it is done only when all the medical measures fail. That is, I think we have to sort of remember. We'll initially treat with medical measures. When everything fails, then transplant is the only option. We do a lot of scoring for that, and depending on the score, MELD score, which is more than 15, then it is an indication for transplant. Or some liver cancers, when they are developing, may be an indication for transplant. Just a small slide on liver cancers. Most common liver cancers are tumors that come from outside the liver, like it can be from the intestines, it can be from the stomach, going into the liver. But I think today we'll talk about the cancers coming inside, arising in the liver, called primary liver cancers, most commonly hepatocellular carcinomas. I think here liver cirrhosis is the commonest cause for hepatocellular carcinoma. Alcohol abuse, a lot of infections with hepatitis viruses, NASH can be a cause, and smoking is an important cause. No particular symptoms are, usually HCC symptoms are very late when they present. Usually it will be at a stage where nothing can be done, but it will be weight loss, loss of appetite, jaundice are the commonest symptoms that are there. We do a lot of tests to diagnose it, CT scan, MRI scan. There can be sometimes we may need a biopsy to do it. We do some blood tests to diagnose it. But we should come to the treatment. Just a brief thing. If detected in an early stage, liver cancers, it can almost 70% of them can be cured. I think we have this misconception that liver cancer, nothing can be done in almost 100%. No. Early stage, 70% can be cured. Because they can be removed surgically, or they can be ablated. Small needle will be passed into the tummy, and the tumor can be burnt off. Ablation can be done. So early stage liver cancers can be cured in majority of individuals. But in advanced stage tumors, obviously there are various options where we block the blood supply to the cancers, or in people with cirrhosis and liver cancers, we advise liver transplantation. So concluding, lifestyle factors contribute most common cause of liver diseases, unfortunately, and all of these are preventable. Healthy lifestyle is the only thing that can prevent these things. Thank you very much. I know I was trying to be very fast and moving through the slides. After that thing, I'll be happy to take any questions. Thank you.
ಇದನ್ನು ಹೆಂಗೆ ತೋರಿಸ್ತೀರಾ? ಅದು ಪವರ್ ಪಾಯಿಂಟಲ್ಲಿ ಬರಲ್ಲ. ಇದು ಇಲ್ಲಿ ಇರುತ್ತೆ ಪಿಕ್ಚರ್, ಅಲ್ಲಿಗೆ ಗೊತ್ತಿಲ್ಲ ನನಗೆ. ಹಾಕಿದೆ ನಾನು, ಇಲ್ಲಿ ಬರ್ತಾ ಇದೆ, ಅಲ್ಲಿ ಬರ್ತಾ ಇಲ್ಲ. ಇನ್ನೂ ಒಂದು ಪಿಕ್ಚರ್ ಇದೆ,
ಇಲ್ಲ ಅದು ಬರ್ತಾ ಇಲ್ಲ, ಅದು ಬರಲ್ಲ.
ಬರೀ ಇಮೇಜ್
ಇದಕ್ಕೆ ಹಾಕ್ಕೊಳ್ಳಿ, ಪಿಕ್ಚರ್ ಎಲ್ಲಿದ್ದು ಅದಕ್ಕೆ ಹಾಕ್ಕೊಂಡ್ರೆ ಬರುತ್ತೆ. ನೋ, ದಟ್ಸ್ ನಾಟ್ ಇಟ್. ಜಸ್ಟ್ ಯಾ, ಐ ಜಸ್ಟ್ ಕಾಪಿ ದಿಸ್, put it in the PowerPoint. Just put it last slide on extra. New slide ಹಾಕಿ blank, paste ಮಾಡಿ. That should come now. PowerPoint ಹಾಕಿದ್ರೆ ಬರುತ್ತೆ ಸರ್. ಇದೆ ಸರ್,
ಇಲ್ಲಿ ಸೆಲೆಕ್ಟ್ ಮಾಡಿ.
ಒಂದು ಸೆಕೆಂಡ್ ಇನ್ನೊಂದು ಪಿಕ್ಚರ್ ಇದೆ. ಒಂದು ನಿಮಿಷ
ಸರ್,
ಯಾ,
ಒಂದು ನಿಮಿಷ. ಎಸ್, ಇಲ್ಲಿ ಬನ್ನಿ ಸರ್, ಇಲ್ಲಿಂದ ಪ್ರಾಬ್ಲಮ್.
ನಾನು ಈ ಪಿಕ್ಚರ್ ಏನಕ್ಕೆ ಹಾಕಿದ್ದೀನಿ ಅಂದರೆ, ಜಾಂಡೀಸ್ ಅಂದ ತಕ್ಷಣ ನಿಮಗೆ ಅಂದರೆ ಏನು ಅಂತ ಗೊತ್ತಾಗಲಿ ಅಂತ. ಏನಂದರೆ ಇದು ನೋಡಿ, ಇದು ಗಾಲ್ ಬ್ಲ್ಯಾಡರ್ ಅಂತ ಹೇಳೋದು, ಅಂದರೆ ಪಿತ್ತಕೋಶ. ಪಿತ್ತಕೋಶದಲ್ಲಿ ಕಲ್ಲುಗಳು ಅಂದರೆ ಹರಳು ಅಥವಾ ಸ್ಟೋನ್ಸ್ ಅಂತ ಏನು ಹೇಳ್ತೀವಿ, ಅದು ಇದ್ದಾಗ ಇದು ತೊಂದರೆ ಕೊಡುತ್ತೆ ಗಾಲ್ ಬ್ಲ್ಯಾಡರ್ಗೆ. ಅದು ಹೀಗೆ ಮುಂದೆ ಹೋಗ್ತಾ ಇರುವಾಗ ಕೆಲವೊಂದು ಸರಿ ಬ್ಲಾಕ್ ಆಗಿಬಿಡುತ್ತೆ. ಬ್ಲಾಕ್ ಆದಾಗ ಇದು ಡಕ್ಟ್, ಇದು ಕಾಮನ್ ಬೈಲ್ ಡಕ್ಟ್ ಅಂತ ಏನು ಹೇಳ್ತೀವಿ, ಇದು ಬಂದು ಈ ಚಿಕ್ಕ ಕರುಳಿಗೆ ಬಂದು ಡ್ರೈನ್ ಆಗುತ್ತೆ. ಯಾಕಂದರೆ ಇದು ಪಿತ್ತ ಅಂತ ಏನು ಹೇಳ್ತೀವಿ, ಅಂದರೆ ಜಾಂಡಿಸ್ ಆಗೋಕ್ಕೆ ಇದು ಎಲ್ಲಾದರೂ ಬ್ಲಾಕ್ ಆದರೆ ಇದು ಕಾರಣ ಆಗುತ್ತೆ. ಸೊ ಲಿವರಿಂದ ಉತ್ಪತ್ತಿಯಾಗಿ ಅದು ಕೆಳಗಡೆ ಬಂದು ಇದರಲ್ಲಿ ಸ್ಟೋರ್ ಆಗುತ್ತೆ, ಈ ಗಾಲ್ ಬ್ಲ್ಯಾಡರಲ್ಲಿ ಸ್ಟೋರ್ ಆಗಿ ಕೆಳಗಡೆ ಬಂದು ಇಂಟೆಸ್ಟೈನ್ಗೆ ಹೋಗುತ್ತೆ. ಇದರಲ್ಲಿ ಏನಾದರೂ ತೊಂದರೆಗಳಾದಾಗ ಜಾಂಡಿಸ್ ಆಗೋದು ತುಂಬ ಕಾಮನ್ನು. ಅಂದರೆ ಲಿವರ್ ಪ್ರಾಬ್ಲಮ್ ಇದ್ದಾಗ, ಅಥವಾ ಈ ಗಾಲ್ ಬ್ಲ್ಯಾಡರ್ದು ಕಲ್ಲುಗಳು ಬಂದು, ಅಥವಾ ಇಲ್ಲೇನೋ ಕ್ಯಾನ್ಸರ್ ಆದಾಗ, ಅಥವಾ ಈ ಡಕ್ಟ್ ಏನಿದೆಯಲ್ಲ ಈ ಡಕ್ಟಲ್ಲಿ ಕಲ್ಲುಗಳು ಬಂದು ಸಿಕ್ಕಾಕೊಂಡಾಗ, ಅಥವಾ ಇಲ್ಲಿ ಏನಾದರೂ ಗಡ್ಡೆಗಳು ಕ್ಯಾನ್ಸರ್ ಆಗಿ ಆದಾಗ, ಅಥವಾ ಇಲ್ಲಿ ಕೊನೆಗೆ ಬರ್ತಾ ಇದೆ, ಇಲ್ಲಿ ಪ್ಯಾಂಕ್ರಿಯಾಸು ಬಂದು ಜಾಯ್ನ್ ಆಗುತ್ತೆ. ಈ ಪ್ಯಾಂಕ್ರಿಯಾಟಿಕ್ ಕ್ಯಾನ್ಸರ್ ಇದ್ದಾಗ, ಅಥವಾ ಈ ಸಣ್ಣ ಕರಳಿನ ಕ್ಯಾನ್ಸರು ಅಥವಾ ಕಲ್ಲುಗಳಿದ್ದಾಗ ಬ್ಲಾಕ್ ಆದಾಗ ಏನಾಗ್ಬಿಡುತ್ತೆ, ಈ ಪಿತ್ತ ಅಲ್ಲೇ ಕೂತ್ಕೊಂಡ್ಬಿಟ್ಟು ಜಾಂಡಿಸ್ ಆಗುತ್ತೆ. ಆವಾಗ ಡಾಕ್ಟ್ರು ಇದು ಅಂದರೆ ಬರೀ ಕಲ್ಲುಗಳಿದ್ದರೆ ಇದನ್ನು ಓಪನ್ ಮಾಡಿ ಇಲ್ಲಿಂದ ರಿಲೀಸ್ ಮಾಡ್ತಾರೆ, ಅಥವಾ ಈ ಗಾಲ್ ಬ್ಲ್ಯಾಡರು ಪಿತ್ತಕೋಶ ತೆಗಿತಾರೆ, ಅಂದರೆ ಕೊಲಿಸ್ಟೆಕ್ಟಮಿ ಅಂತ ಏನು ಹೇಳ್ತಾ ಇದ್ರು ಇವಾಗ, ಅದನ್ನು ತೆಗೆಯೋದು. ಈ ರೀತಿಯಾಗಿ ವಿಧವಾದ ಚಿಕಿತ್ಸೆಗಳಿರುತ್ತೆ. ಇನ್ನೊಂದು ಪಿಕ್ಚರ್ ತೋರಿಸ್ತೀನಿ ನಿಮಗೆ. ಇರಲಿ ಸೇಮ್ ಅದೇ ನಿಮಗೆ ಗೊತ್ತಾಗಲಿ ಅಂತ ಇದನ್ನು ಹೇಳ್ತಾ ಇರೋದು. ಯಾಕೆಂದರೆ ಪಿಕ್ಚರ್ ನೋಡಿದರೆ ತುಂಬ ಈಸಿಯಾಗಿ ಗೊತ್ತಾಗ್ಬಿಡುತ್ತೆ. ಇದು ಲಿವರಲ್ಲಿ ಏನು ಗಡ್ಡೆಗಳಾಗಲಿ, ಕ್ಯಾನ್ಸರ್ ಗಡ್ಡೆ ಆಗಲಿ, ಬೇರೆದು ಯಾವುದೇ ಗಡ್ಡೆಗಳಾಗಲಿ, ಏನೇ ಲಿವರ್ಗೆ ತೊಂದರೆ ಆದಾಗ ಜಾಂಡಿಸ್ ಆಗುತ್ತೆ. ಯಾಕಂದರೆ ಉತ್ಪತ್ತಿ ಆಗೋದೇ ಇಲ್ಲಿ, ನಮ್ಮ ಪಿತ್ತ ಉತ್ಪತ್ತಿ ಆಗೋದೇ ಇಲ್ಲಿ, ಮತ್ತು ಅದು ಹರ್ಕೊಂಡು ಇಲ್ಲಿ ಮುಂದೆ ಬರುತ್ತೆ, ಇಲ್ಲಿ ಸ್ಟೋರ್ ಆಗುತ್ತೆ, ಇಲ್ಲಿ ಕಲ್ಲುಗಳಿದ್ರೂ ಆಗುತ್ತೆ. ಮುಂದೆ ಏನೋ ನ್ಯಾರೋಯಿಂಗ್ ಆಗಿದೆ, ಏನೋ ಒಂದು ಹೊರಗಡೆ ಕಂಪ್ರೆಷನ್ ಇದೆ, ಅಥವಾ ಒಳಗಡೆ ಗಡ್ಡೆ ಇದೆ, ಇದು ಮುಂದೆ ಹೀಗೆ ಬಂದು ಇಲ್ಲಿಗೆ ಹರ್ಕೊಂಡು ಹೋಗಬೇಕು. ಅಂದರೆ ನಮ್ಮ ಅನ್ನನಾಳಕ್ಕೆ ಬಂದು ಹರ್ಕೊಂಡು ಹೋಗುತ್ತೆ, ಅಲ್ಲಿ ಫುಡ್ ಬಂದು ಅದ್ರ ಜೊತೆ ಮಿಕ್ಸ್ ಆಗಿ ಡೈಜೆಸ್ಟ್ ಚೆನ್ನಾಗಾಗುತ್ತೆ. ಸೊ ಇದರಲ್ಲಿ ಎಲ್ಲೇ ಬ್ಲಾಕ್ ಇದ್ರೂ, ಈಗ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ ಇದು ಪ್ಯಾಂಕ್ರಿಯಾಟಿಕ್ ಡಕ್ಟು, ಇದು ಪ್ಯಾಂಕ್ರಿಯಾಟಿಕ್ ಕ್ಯಾನ್ಸರು ಎಲ್ಲೇ ಬ್ಲಾಕ್ ಇದ್ರೂ ಆವಾಗ ನಮಗೆ ಜಾಂಡಿಸ್ ಆಗೋ ಚಾನ್ಸಸ್ ಇರುತ್ತೆ. ಸೊ ಜಾಂಡಿಸನ್ನು ಅಷ್ಟೊಂದು ಸಿಂಪಲ್ಲಾಗಿ ತೊಗೋಬಾರ್ದು, ಅದೊಂದು ಇಂಡಿಕೇಟರ್ ಏನೋ ಸಮಥಿಂಗ್ ಸೀರಿಯಸ್ ಇದೆ ಅಂತ. ಸೊ ಅದನ್ನು ಡಾಕ್ಟರ್ಸ್ ಹತ್ರ ಹೋದರೆ ಅದು ಕರೆಕ್ಟಾಗಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಆಗುತ್ತೆ. ಜಸ್ಟ್ ಟು ಇಂಪ್ರೆಸ್ ಯು ಅಪಾನ್ ಹೌ ಇಂಪಾರ್ಟೆಂಟ್ ಇಟ್ ಈಸ್, ಅದಕ್ಕೆ ನಾನು ಇದು ಪಿಕ್ಚರ್ ಹಾಕಿದೆ. ಥ್ಯಾಂಕ್ ಯು.
ಈಗ ನಾನು ಆದಷ್ಟು ನಾವು ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಆದಷ್ಟು ನಾನು ಪೇಷಂಟಾಗಿ ನೀವು ಯಾವ್ಯಾವ ಕ್ವಶನ್ಗಳು ಕೇಳ್ಬೋದು ಅನ್ನೋದನ್ನು ಮುಂಚೆನೇ ತಿಳ್ಕೊಂಡು ಅದನ್ನು ನನ್ನ ಇದರಲ್ಲಿ ಮಾತುಕತೆಯಲ್ಲಿ ನಾನು ಅದನ್ನು ಅಡ್ರೆಸ್ ಮಾಡಿದ್ದೀನಿ. ಅದಕ್ಕೆ ಎಷ್ಟೋ ಜನಕ್ಕೆ ಇನ್ನೂ ಹಲವಾರು ಡೌಟ್ಗಳಿರ್ಬೋದು. ದಯವಿಟ್ಟು ಈಗ ಇದು ಒಂದು ಫೋರಮ್ ಇರೋದೇ ನಿಮ್ಮ ಪ್ರಶ್ನೆಗಳೇನಿರುತ್ತೆ ಅದನ್ನು ನಾವು ಸಮಂಜಸವಾಗಿ ಉತ್ತರ ಕೊಡಲಿಕ್ಕೆ. ಸೊ ದಯವಿಟ್ಟು ಪ್ಲೀಸ್ ಆಸ್ಕ್ ಯುವರ್ ಕ್ವಶನ್ಸ್ ಆ್ಯಂಡ್ ವಿಲ್ ಹ್ಯಾಪಿಲಿ ಆನ್ಸರ್ ದೆಮ್. ಇದು ಬಂದಿದೆ ಅಂದರೆ ಜನರಲ್ ಆಗಿ ಯಾವ ಮೆಡಿಸನ್ ತೊಗೋಬೋದು ಸರ್? ಸ್ಟಾರ್ಟಿಂಗ್ ಸ್ಟೇಜ್ನಲ್ಲಿ ವಿತೌಟ್ ನೋಟಿಸ್ ಯಾರಿಗೂ ಹೇಳ್ದಿರಾ ಯಾವ ಮೆಡಿಸನ್ ತೊಗೋಬೋದು?
ಅಲ್ಲ, ಇದು ಯಾವ ಕಂಡೀಷನ್ ನಿಮ್ಮದು? ಜಾಂಡಿಸಾ ಅಥವಾ ಪಿತ್ತಕೋಶದ ಕಲ್ಲ?
ಜಾಂಡಿಸ್ ನಮ್ಮ ಅಡಲ್ಟ್ಸಲ್ಲಿ, ನಮ್ಮ ದೊಡ್ಡವರಲ್ಲಿ. ಚಿಕ್ಕ ಮಕ್ಕಳ ಜಾಂಡಿಸ್ ಬಗ್ಗೆ ನಾವು ಮಾತಾಡೋದು ಬೇಡ. ದೊಡ್ಡವರಲ್ಲಿ ಜಾಂಡಿಸ್ ಬಂದಿದೆ ಅಂದರೆ ಒಂದು ಆಬ್ವಿಯಸ್ಲಿ ಐ ಥಿಂಕ್ ಹೇಳಿರ್ತಾರಲ್ಲ, 2 ಥರದ ಜಾಂಡಿಸ್ ಇದೆ ನಮಗೆ. ಒಂದು ಮೆಡಿಕಲ್ ಜಾಂಡಿಸ್ ಅಂತ, ಒಂದು ಸರ್ಜಿಕಲ್ ಜಾಂಡಿಸ್ ಅಂತ. ಮೆಡಿಕಲ್ ಜಾಂಡಿಸಲ್ಲಿ ಕಾಮನ್ ಏನಕ್ಕಾಗುತ್ತೆ ಅಂದರೆ ನಮ್ಮ ಒಂದು ವೈರಸ್ ಇನ್ಫೆಕ್ಷನ್. ನಮಗೆ ಕಾಮನೆಸ್ಟ್ ಆಗೋದು ಹೆಪಟೈಟಿಸ್ ಎ ಅಂತ ವೈರಸ್ ಇನ್ಫೆಕ್ಷನ್ನು. ಅದು ನಮ್ಮ ಊಟ ಹೊರಗಡೆ ಎಲ್ಲಾದರೂ ಅನ್ಕ್ಲೀನ್ ಆಗಿರೋದು, ನೀರು, ಅದರಿಂದ ಬರೋವಂಥದ್ದು. ಇದು ಕಾಮನೆಸ್ಟ್ ಜಾಂಡಿಸ್ ಅದೇ ಹೆಪಟೈಟಿಸ್ ಎ. ಅದಕ್ಕೆ ಏನೂ ಟ್ಯಾಬ್ಲೆಟ್ 90% ಏನೂ ಮಾತ್ರೆಗಳು ಔಷಧಿಗಳಿಲ್ದಂಗೆ ತಂತಾನೇ ವಾಸಿ ಆಗುತ್ತದು. ನಮ್ಮ ದೇಹನೇ ಅದನ್ನು ಇದು ಮಾಡುತ್ತೆ. ಅದನ್ನೇ ಸಾಮಾನ್ಯ ಜನಗಳೆಲ್ಲ ನಂಬ್ಕೊಂಡು ಹೋಗೋದು, ಆ ವೈದ್ಯರು ಈ ವೈದ್ಯರು ಕೊಟ್ಟರೆ ತಮ್ಮ ಜಾಂಡಿಸ್ ವಾಸಿ ಆಯಿತು ಅಂತ. ಬಟ್ ಆ್ಯಕ್ಚುಲಿ ಅವ್ರು ಕೊಟ್ಟಿದ್ದಕ್ಕಲ್ಲ ಅದು ವಾಸಿಯಾಗಿರೋದು, ಅದು ತಂತಾನೇ ವಾಸಿ ಆಗೋದು. ಅದೇ ಕಾಮನೆಸ್ಟ್, ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಅದೇ ಕಾಮನೆಸ್ಟ್ ಫಾರ್ಮ್ ಆಫ್ ಜಾಂಡಿಸ್. ಬಟ್ ಇದು ಸುಮಾರು ದಿವಸ ಆದರೂ ಅದು ವಾಸಿ ಆಗಲಿಲ್ಲ ಅಂದರೆ, ಅಟ್ಲೀಸ್ಟ್ ಒಂದು ವಾರ 15 ದಿವಸನಾದರೂ ಅದು ವಾಸಿ ಆಗ್ತಿಲ್ಲ ಅಂದರೆ ಡೆಫಿನೆಟ್ಲಿ ಡಾಕ್ಟ್ರ್ ಹತ್ರ ಹೋಗ್ರಿ. ಯಾವುದು ಮೆಡಿಸಿನ್, ನಿಮಗೆ ನೀವೇ ಯಾವುದೂ ಮೆಡಿಸಿನ್ ತೊಗೊಳಕ್ಕೆ ಹೋಗಬೇಡಿ. ಡೆಫಿನೆಟ್ಲಿ ನಾನು ಯಾವತ್ತೂ ಅದು ಅಡ್ವೈಸ್ ಮಾಡೋದಿಲ್ಲ. ನಿಮಗೆ ನೀವೇ ಯಾವ ಮೆಡಿಸಿನು ತೊಗೊಳಕ್ಕೆ ಹೋಗಬೇಡಿ. ದೊಡ್ಡವರಲ್ಲಿ ಅಡಲ್ಟ್ಸಲ್ಲಿ ಬರೋ ಜಾಂಡಿಸ್ಸು ಕಲ್ಲುಗಳಿಂದ, ಪಿತ್ತಕೋಶದ ಕಲ್ಲುಗಳಿಂದ ಆಗಿರ್ಬೋದು, ಇಲ್ಲ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಕೆಲವೊಂದು ಕ್ಯಾನ್ಸರ್ಸಿಂದನೂ ಸಾಕಷ್ಟು ಜಾಂಡಿಸ್ ಬರುತ್ತೆ, ಅದು ಆಗಿರ್ಬೋದು. ಸೊ ಅದನ್ನು ನಾವು ಮೊದಲೇ ಡಿಟೆಕ್ಟ್ ಮಾಡಿ ಅದನ್ನು ಅರ್ಲಿ ಸ್ಟೇಜಲ್ಲಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿದಾಗ ಅದನ್ನು ಕಂಪ್ಲೀಟಾಗಿ ವಾಸಿ ಮಾಡ್ಬೋದು. ಸೊ ಮಾತ್ರೆಗಳು, ಔಷಧಿಗಳನ್ನ ತೊಗೊಳಕ್ಕೆ ಹೋಗಬೇಡಿ. ಡಾಕ್ಟ್ರ್ ಹತ್ರ ಹೋಗಿ ಕರೆಕ್ಟಾಗಿ ಡಯಾಗ್ನೋಸ್ ಮಾಡಲಿ.
ಸೊ ಸಿಂಪಲ್ ಆನ್ಸರ್ ಅಂದರೆ, ಮೊದಲು ನೀವು ಯಾವುದು ಮಾತ್ರೆಗಳು ತೊಗೊಳಕ್ಕೆ ಹೋಗ್ದಲೇ ಜಾಂಡಿಸ್ ಬಂದಾಗ ಇಟ್ ಈಸ್ ಯಾವುದೋ ಒಂದು ಕಾರಣ ಇರುತ್ತೆ. ಅದಕ್ಕೆ ಕಾರಣ ಹುಡುಕ್ದಲೇ ನೀವೇ ಯಾವುದು ಮಾತ್ರೆ ತೊಗೊಳೋದು ಬೇಡ. 1 ವಾರ ತನಕನೂ ಕಾಯೋದೂ ಬೇಡ. ಮೋಸ್ಟ್ ಆಫ್ ದ ಟೈಮ್ಸ್ ಬೆಟರ್ ಟು ಗೋ ಟು ಡಾಕ್ಟರ್. ಆಮೇಲೆ ಅವರು ಇನ್ವೆಸ್ಟಿಗೇಟ್ ಮಾಡಿ ಹೇಳ್ತಾರೆ, ನಿಮಗೇನು ಮೆಡಿಸಿನ್ ಬೇಡ ಅಂದರೆ ಬೇಡ ಅಂತ ಹೇಳ್ತಾರೆ.
ನಾನು ನಮ್ಮ ಮಾತಲ್ಲೇ ಹೇಳಿದಾಗೆ, ಡೋಂಟ್ ಸೆಲ್ಫ್ ಮೆಡಿಕೇಟ್, ಡೋಂಟ್ ನೆಗ್ಲೆಕ್ಟ್ ದ ಪ್ರಾಬ್ಲಮ್. ಎರಡೂ ತಪ್ಪು. ಫಸ್ಟ್ ಕಾರಣ ತಿಳ್ಕೊಂಡ್ಮೇಲೆ ನೀವು ಆಮೇಲೆ ಆಯುರ್ವೇದ, ಯುನಾನಿ, ಇದು ಹೋಮಿಯೋಪತಿ, ಅದು ನಿಮ್ಮ ಇಚ್ಛೆ. ಆದರೆ ಫಸ್ಟು ಈ ಜಾಂಡೀಸ್ ಬಂದಿರೋ ಕಾರಣ ಏನು ಅಂತ ತಿಳ್ಕೊಬೇಕು. ಅದನ್ನು ತಿಳ್ಕೊಳ್ಳೋ ತನಕ ದಯವಿಟ್ಟು ಯಾವ ಟ್ರೀಟ್ಮೆಂಟು ನೀವೇ ತೊಗೊಳಕ್ಕೆ ಹೋಗಬೇಡಿ. ಅದು ನಮ್ಮ ಕಳಕಳಿಯ ಮನವಿ ನಿಮಗೆ. ಹಾಂ, ಹೇಳಿ ಸರ್.
ಯಾವ ಡ್ರಿಂಕು, ದಟ್ಸ್ ಅ ಮಿತ್. ಐ ಥಿಂಕ್ ರೀಸೆಂಟಾಗಿ ಜಸ್ಟ್ ಈ ವರ್ಷನೇ ಸ್ಟಡಿ ಬಂತು, 1 ಡ್ರಿಂಕ್ ಅಲ್ಲ, 1 ಡ್ರಾಪ್ ಡ್ರೇ ಈಸ್ ಆಲ್ಸೋ ಡೇಂಜರಸ್ ಅಂತ. ಸೊ ಅದು ಯಾರೋ ಕುಡಿಯೋರು ಅವ್ರಿಗೆ ತಕ್ಕನಾಗೆ ವಾಟ್ಸಪ್ ಯೂನಿವರ್ಸಿಟಿಲಿ ಹಾಕ್ಕೊಂಡಿರ್ಬೋದು. ಬಟ್ ಅದು ಕಂಪ್ಲೀಟ್ಲಿ ಫಾಲ್ಸ್. ಹಾರ್ಟ್ಗೂ ಡ್ರಿಂಕ್ಸ್ಗೂ ಯಾವ ಸಂಬಂಧ ಇಲ್ಲ ಅಂತ ಈಗ ಈ ವರ್ಷನೇ ಬಂದಿರೋ ಸ್ಟಡೀಲಿ ಪ್ರೂವ್ ಆಗಿದೆ. ಸೊ ಅದಕ್ಕೆ ಯಾವ ಇದು ಇಲ್ಲ. ಅದು ವೈನ್ ತೊಗೊಂಡ್ರೂ ಕಡಿಮೆ ಆಗುತ್ತೆ, ಇದಾಗುತ್ತೆ, ಹಾರ್ಟ್ಗೆ ಒಳ್ಳೆಯದು, ಡೈಲೇಟ್ ಆಗುತ್ತೆ ಅಂತ ಕಂಪ್ಲೀಟ್ ಮಿತ್. ಅದಕ್ಕೆ ಯಾವ ಇದು ಇಲ್ಲ, ಯಾವ ಎವಿಡೆನ್ಸ್ ಇಲ್ಲ ಅದಕ್ಕೆ.
ಅದೇ ಈಗ ರೆಡ್ ವೈನ್ ಈಸ್ ಕಾಮನ್ಲಿ ಕೋಟೆಡ್. ಸೊ ರೆಡ್ ವೈನ್ ಸಪೋಸ್ ಟು ಪ್ರೊಟೆಕ್ಟ್ ದ ಹಾರ್ಟ್. ಐ ಡೋಂಟ್ ಥಿಂಕ್ ದೆರ್ ಈಸ್ ಇನಫ್ studies to prove that. So as of now there is no proof that alcohol has any protective action. Amele there are 2 types of people who are slow acetylators and fast acetylators anta. So people who can metabolize alcohol quickly, they may escape the damage. You can see there are certain people who commonly quote as drink like fish and still not get any problem. They are lucky because they are fast acetylators, and so the alcohol is acetylated and excreted from the body quickly, so it doesn't have the time to damage the liver. Slow acetylators will not be able to do that. But we will not be, even with any number of investigations, we won't be able to tell whether you are a fast or a slow acetylator. So safe wise, don't drink. But if you drink, you have to be prepared for the consequences.
ಐ ಥಿಂಕ್ ಹಾಕಿದ್ದೆ ನಾನು ಅದನ್ನು ಹೇಳಲಿಲ್ಲ, ಯಾಕೆಂದರೆ ಅದು ತುಂಬ ಟೆಕ್ನಿಕಲ್ ಟರ್ಮ್ ಆಗುತ್ತೆ ಅಂತ. ನ್ಯಾಶ್ ಅಂದರೆ ನಾನ್ ಆಲ್ಕೋಹಾಲಿಕ್ ಸ್ಟಿಯಟೋಹೆಪಟೈಟಿಸ್ ಅಂತ. ಆ ವರ್ಡಲ್ಲೇ ನೋಡ್ಕೊಂಡು ಹೋದರೆ ಆಲ್ಕೋಹಾಲ್ ತೊಗೊಂಡಿಲ್ದಿರೋರಲ್ಲಿ ಫ್ಯಾಟಿ ಲಿವರ್ ಆಗಿ ಅದರಿಂದ ಡ್ಯಾಮೇಜ್ ಆಗೋದು. ನಾನ್ ಆಲ್ಕೋಹಾಲಿಕ್ ಸ್ಟಿಯಟೋಹೆಪಟೈಟಿಸ್ ಅಂದರೆ ಸ್ಟಿಯಟೋ ಅಂದರೆ ಫ್ಯಾಟ್, ಹೆಪಟೈಟಿಸ್ ಅಂದರೆ ಲಿವರ್ದು ಇನ್ಫ್ಲಮೇಷನ್. ನ್ಯಾಶ್ ಅಂದರೆ HCC ಅಂತಲೂ ಹಾಕಿದ್ದೆ, ನಾನು ಹೇಳಿದ್ದೀನಿ ಅದನ್ನು, ಹೆಪಟೋಸೆಲ್ಲರ್ ಕಾರ್ಸಿನೋಮಾ ಅಂತ. ಅದು ಕಾಮನೆಸ್ಟ್ ಟೈಪ್ ಆಫ್ ಪ್ರೈಮರಿ ಲಿವರ್ ಕ್ಯಾನ್ಸರ್. ಲಿವರಿಗೆ ಬರೋ ಫಸ್ಟ್ ಕ್ಯಾನ್ಸರ್ಸಲ್ಲಿ ಅದು ಕಾಮನೆಸ್ಟ್ ಕ್ಯಾನ್ಸರು. ಈ ಸಿರೋಸಿಸ್ಸು ಲಿವರ್ ಡ್ಯಾಮೇಜಿಂದನೇ ಅದು ಕಾಮನ್ ಆಗಿ ಆಗೋದು.
Other questions, please? Sir?
What on earth is the real cause of cancer?
ವಿಶ್ ವಿ ಆಲ್ ನ್ಯೂ.
ಸಿಂಪಲ್ಲಾಗಿ ಹೇಳ್ಬೇಕಂದ್ರೆ ಹಣೆ ಬರ.
Sir, cancers are, it is an interplay of several factors, including.
Name one only factor.
There is no only factor for it, because different cancers have different. For example, lung cancer, you have smoking, and so similarly there are several cancers which have different alcohol for liver cell cancer. So there are different causes for different cancer, but there cannot be one cause for all cancers. It's not a one size fits all. It doesn't work like that.
I will spell out the real cause for all the cancers. Will you hear it?
Yes, sir.
I mean, there can be a modifiable cause or a non-modifiable cause. Basically, the most important thing is, as you age, many of us will get cancer. Older the age will get cancer, but unfortunately that is something that we can't modify. What is cancer is, I mean, in our body, every day there will be some mutations happening in our body. ಸ್ವಲ್ಪ ಮ್ಯೂಟೇಷನ್ಸ್ ಆಗ್ತಾನೆ ಇರ್ತವೆ. ಬಟ್ ಈ ಮ್ಯೂಟೇಷನ್ಸ್ ನಮ್ಮ ಇಮ್ಯುನಿಟಿ ಫೈಟ್ ಮಾಡಿ ಕ್ಯಾನ್ಸರ್ ಮ್ಯೂಟೇಷನ್ಸ್ ಆಗ್ತಾನೆ ಇರ್ತವೆ, ಎವ್ರಿ ಡೇ ಆಗ್ತಿರ್ತದೆ. ನಮ್ಮ ಇಮ್ಯುನಿಟಿ ಅದನ್ನು ಫೈಟ್ ಮಾಡಿ ಇಟ್ ವಿಲ್ ಸಪ್ರೆಸ್ ಇಟ್ ಆಫ್. ಬಟ್ ಕೆಲವೊಂದು ಸತಿ ಬೈ ಚಾನ್ಸ್, ಆರ್ ಇಫ್ ಯುವರ್ ಇಮ್ಯುನಿಟಿ ಈಸ್ ಲೋ, ಆರ್ ಇಫ್ ಯು ಆರ್ ಟೇಕಿಂಗ್ ಎಕ್ಸ್ಟರ್ನಲ್ ಏಜೆಂಟ್ಸ್, ಲೈಕ್ ದ ಕಾಮನೆಸ್ಟ್ ಕಾಸ್ ಇಸ್ ಸ್ಮೋಕಿಂಗ್. ಸ್ಮೋಕಿಂಗ್ ಈಸ್ ಲೈಕ್ ಇಟ್ ಕ್ಯಾನ್ ಕಾಸ್ ಲಾಟ್ ಆಫ್ ದ ಕ್ಯಾನ್ಸರ್ಸ್. ನಮ್ಮ ದೇಹದಲ್ಲಿ ಬರೋ ಸುಮಾರು ಕ್ಯಾನ್ಸರ್ಗೆ ಸ್ಮೋಕಿಂಗ್ ಪ್ರೈಮರಿ ಕಾಸ್. ಆ್ಯಕ್ಟಿವ್ ಸ್ಮೋಕಿಂಗ್ ಇರ್ಬೋದು, ಪ್ಯಾಸಿವ್ ಸ್ಮೋಕಿಂಗೂ ಇರ್ಬೋದು. ಈ ಥರ ಎಕ್ಸ್ಟ್ರಾ ಏಜೆಂಟ್ಸ್ ನಮ್ಮ ದೇಹದಲ್ಲಿ ಬಂದಾಗ ವಿಚ್ ವಿಲ್ ಸಪ್ರೆಸ್ ಅವರ್ ಇಮ್ಯುನಿಟಿ, ಆರ್ ಆ ಮ್ಯೂಟೇಷನ್ಸ್ ಆಗೋದನ್ನು ಜಾಸ್ತಿ ಮಾಡಿದಾಗ ನಮ್ಮ ಇಮ್ಯುನಿಟಿ ಯಾವಾಗ ಆ ಮ್ಯೂಟೇಷನ್ಸ್ನ ಅದನ್ನು ರೆಕಗ್ನೈಸ್ ಮಾಡಲ್ವೋ, ಅಥವಾ ಅದು ಆ ಮ್ಯೂಟೇಷನ್ಸ್ ಎಷ್ಟು ಸ್ಟ್ರಾಂಗ್ ಆಗಿಬಿಡ್ತತೆ ಅಂದರೆ ನಮ್ಮ ಇಮ್ಯುನಿಟಿಗಿಂತ ಸ್ಟ್ರಾಂಗ್ ಆದಾಗ ಕ್ಯಾನ್ಸರ್ ಬರುತ್ತೆ. ಅದಕ್ಕೆ ಕ್ಯಾನ್ಸರ್ ಈಸ್ ಅ ವೆರಿ ಕಾಂಪ್ಲೆಕ್ಸ್ ಇಂಟರ್ಪ್ಲೇ ಆಫ್ ಮೆನಿ ಫ್ಯಾಕ್ಟರ್ಸ್, ಬಟ್ ಇದು ಆ್ಯಸ್ ಸಿಂಪಲ್ ಆ್ಯಸ್ ಪಾಸಿಬಲ್ ಐ ಹ್ಯಾವ್ ಸಾರ್ಟ್ ಆಫ್ ಎ ಪುಟ್ ಇಟ್.
Sir, so far from the explanation what you have given about both the jaundice and liver, is the jaundice is closely associated with cancer, or is there any just chance of cancer?
There is a chance of cancer ಅಷ್ಟೇ. With jaundice, jaundice is not ಇದು ಕಾಯಿಲೆ ಅಲ್ಲ. ಜಾಂಡಿಸ್ ಕಾಯಿಲೆ ಅಲ್ಲ. ಜಾಂಡಿಸ್ ಈಸ್ ಓನ್ಲಿ ಎ ಸಿಂಪ್ಟಮ್. ಕಾಯಿಲೆ ಏನು ಅಂತ ನಾವು ಕಂಡುಹಿಡಿಬೇಕು. ಸೊ ಜಾಂಡಿಸ್ ಅನ್ನೋದು ಒಂದು ಕಾಯಿಲೆ ಅಲ್ಲ, ಅದನ್ನು ನಾವು ಈಗಲೇ ಅರ್ಥ ಮಾಡ್ಕೋಬೇಕು. ಅದು ಓನ್ಲಿ ಎ ಸಿಂಪ್ಟಮ್. ಅದು ಏನಕ್ಕಾಗಿದೆ, ಅದು ಸುಮಾರು ಕಾಯಿಲೆಗಳಿಂದ ಜಾಂಡಿಸ್ ಆಗ್ಬೋದು. ಅದು ಕೆಲವೊಂದು ಸಿಂಪಲ್ ವೈರಸ್ ಇನ್ಫೆಕ್ಷನಿಂದನೂ ಆಗ್ಬೋದು, ಇಲ್ಲ ಕಾಂಪ್ಲೆಕ್ಸ್ ಕ್ಯಾನ್ಸರ್ಸಿಂದನಾದರೂ ಆಗ್ಬೋದು. ತುಂಬ ಕಾರಣಗಳಿದ್ದಾವೆ. ಅದನ್ನು ನಾವು ಕರೆಕ್ಟಾಗಿ ಕಂಡುಹಿಡಿಬೇಕಷ್ಟೇ. ಅದನ್ನು ಕಂಡುಹಿಡ್ದು ಅದನ್ನು ಟ್ರೀಟ್ ಮಾಡಬೇಕು ನಾವು.
ನಂದು ಫಸ್ಟ್ ಸ್ಲೈಡಲ್ಲಿ, ಸೆಕೆಂಡ್ ಸ್ಲೈಡಲ್ಲಿ I had put up there is even more exhaustive list. ಬಟ್ ಅದಕ್ಕೆ ನಾ ಹೇಳಿದ್ದು, ದಯವಿಟ್ಟು ಜಾಂಡೀಸ್ನ ನೆಗ್ಲೆಕ್ಟು ಮಾಡಬೇಡಿ, ಸೆಲ್ಫ್ ಮೆಡಿಕೇಟು ಮಾಡಬೇಡಿ. ಫಸ್ಟ್ ಆಫ್ ಆಲ್, ಇಫ್ ಯು ಐಡೆಂಟಿಫೈ ದ ಕಾಸ್ ಫಾರ್ ಜಾಂಡೀಸ್, ದೆನ್ ಇಫ್ ಇಟ್ ಈಸ್ ಸಮಥಿಂಗ್ ಸಿಂಪಲ್, ವಿ ಡೋಂಟ್ ಹ್ಯಾವ್ ಟು ಡೂ ಎನಿಥಿಂಗ್ ಫರ್ದರ್. ವಿ ಕ್ಯಾನ್ ಜಸ್ಟ್ ವಾಚ್ ಆ್ಯಂಡ್ ವೆಯ್ಟ್. ಬಟ್ ಇಫ್ ಇಟ್ ಈಸ್ ಸಮಥಿಂಗ್ ಸೀರಿಯಸ್, ಮೋಸ್ಟ್ ಲೈಕ್ಲಿ ವಿ ಮೈಟ್ ಹ್ಯಾವ್ ಪಿಕ್ಡ್ ಇಟ್ ಅಪ್ ಅರ್ಲಿ ಆ್ಯಂಡ್ ವಿ ಕ್ಯಾನ್ ಟ್ರೀಟ್ ಇಟ್. ಸೊ ಅರ್ಲಿಯರ್ ಇಟ್ ವಿಲ್ ಬಿ ಬೆಟರ್. ಆಮೇಲೆ ಇವರು ಹೇಳಿದಾಗೆ there is something called mismatch repair genes which are coming in a big way in the body, in the investigative armamentarium. ಈಗ that is initially come from the colorectal cancer. ಏನಂದರೆ ಆ್ಯಸ್ ಈ ಸಾರ್ ಹೇಳಿದಾಗೆ, the body cells are all multiplying very rapidly. Blood cells are multiplying rapidly, hair cells, skin, body intestine layer, the mucosa or the lining of the intestine, they all multiply rapidly. When they multiply rapidly, there is a chance there is mutation and mitosis. But there are genetic coding ಗೊತ್ತಿದ್ರೆ, the coding happens according to the the particular genes that code that particular cell or whatever. So when that coding goes wrong, there are mismatch repair genes which are there in the body which will repair these mutations and prevent them from multiplying further and becoming cancer. So when the mismatch repair genes are altered or they're disabled by the toxic agents like smoking or in case of liver alcohol and things like that, then the cells will then multiply rapidly. They will become initially what we call as dysplasia, which is the normal cell will become metaplastic, that is it will change, then it will become dysplastic, which will be very away from the normal cell, and then finally it will become neoplasia, which is cancer. So that stage goes through, and you will be surprised to know, of course some of the very aggressive ones may be faster, but generally it takes about 7 to 14 years for a cell to have attained the stage where it becomes a cancer. So it is going on quite a lot inside before it manifests. They say that a breast cancer to attain 1 centimeter size will take about 14 to 15 mutations for it to cycles for it to reach that. So it is all a slow process. But when they manifest, then they can become very aggressive, depending on the all other biological factors of the cancer. So the simple answer is it is a multifactorial thing. I don't know if there is one factor which causes breast cancer. If I am you please tell us, sir.
Trichloroethane, that is the culprit. ಎಲ್ಲರ ಮೆಷರ್ಮೆಂಟ್ ಥ್ರೂಔಟ್ and ಯೂಸ್ ಮಾಡ್ತಾ ಬಂದರು, ಎಲ್ಲ ಕಡೆ ಸಿಂಪಡಿಸಿದ್ರು, ಆ ವಾಸನೆ ಕ್ಯಾನ್ಸರ್ ಬಂದಿದೆ.
Definitely one of the factors may be.
One of the only factor ಅಂತ ಹೇಳಿದ್ದು, main factor.
I will agree to that. It may
EDT is one of the factors for certain cancers, but not.
It cannot be the only factor.
Cancer is hereditary.
There is a hereditary cancers also.
So very small amount of cancers are hereditary, very, very little. Majority are not.
Sir, any excessive use of fruits or vegetables will cause stones in the bladder. Like tomato, if you use more tomato, it will cause stones in the bladder. Like that, there is a
For gallbladder stones, no, sir. Not for gallbladder stone. We are not talking about kidney stones. Kidney stones, there are oxalates. I mean, there are a lot of factors. But I think gallbladder stones, gilla, sir. Atara ಏನು ಇಲ್ಲ.
Gallstones gilla. Coffee is protective. Unlike popular belief, 2 cups of coffee is protective against chest disease, heart disease, colon cancer, pancreatic cancer. It is all scientifically proven. But having 14-15 cups of coffee is quite harmful, and it can cause damage. But coffee will not cause gallbladder stones. That much is true.
What about tea?
Same for tea. Coffee is better because it contains better. Tea contains a lot more other alkaloids.
Nationally, diabetes day. Earlier they focus was on sugar or glucose. Nowadays they focus has shifted to fructose. And I'm getting a lot of market. So can you please? Because fructose is now ಹಣ್ಣು ಕೂಡ ತಿನ್ನಬಾರ್ದು ಅಂತ
ಸೊ ನಮಗೆ ಯಾವಾಗಲೂ ಈಗ ಫ್ಯಾಟಿ ಲಿವರ್ ಅಂದರೆ ಮನಸ್ಸಿಗೆ ಬರೋದು ನಾವು ಫ್ಯಾಟ್ಸಿಂದ ಬರುತ್ತೆ ಅಂತ. ಬಟ್ ಆ್ಯಕ್ಚುಲಿ ದ ಬಿಗ್ಗರ್ ಕಲ್ಪ್ರಿಟ್ ಇಸ್ ಕಾರ್ಬೋಹೈಡ್ರೇಟ್ಸ್, ಸಿಂಪಲ್ ಕಾರ್ಬೋಹೈಡ್ರೇಟ್ಸ್. ಈ ಗ್ಲೂಕೋಸ್, ಫ್ರಕ್ಟೋಸ್ ಇವೆಲ್ಲ ಸಿಂಪಲ್ ಕಾರ್ಬೋಹೈಡ್ರೇಟ್ಸ್ ವೇರ್ ತುಂಬ ಈಸಿಯಾಗಿ ನಮಗೆ ಬ್ರೇಕ್ ಡೌನ್ ಆಗಿ ನಿಮ್ಮ ಲಿವರಿಗೆ ರೀಚ್ ಆಗುತ್ತೆ. ಹೈ ಕ್ವಾಂಟಿಟಿಲಿ ಫ್ರಕ್ಟೋಸ್ ಅಥವಾ ಗ್ಲೂಕೋಸ್ ಅಥವಾ ಸುಕ್ರೋಸ್ ಅಂದರೆ ಗ್ಲೂಕೋಸ್ ವಿತ್ ಫ್ರಕ್ಟೋಸ್. ಸೊ ಯಾವುದೇ ಇವೆಲ್ಲ ಸಿಂಪಲ್ ಶುಗರ್ಸ್. ಈ ಸಿಂಪಲ್ ಶುಗರ್ಸ್ ಎಲ್ಲನೂ ಅಷ್ಟೇ ಡ್ಯಾಮೇಜ್ ಮಾಡುತ್ತೆ ಲಿವರ್ಗೆ ಇಫ್ ದೇ ಆರ್ ಟೇಕನ್ ಇನ್ ಹೈ ಕ್ವಾಂಟಿಟೀಸ್. ಓಕೆನಾ? ಮಾಡ್ರೇಷನಲ್ಲಿ ಫ್ರೂಟ್ಸಲ್ಲಿ ಏನೂ ಪ್ರಾಬ್ಲಮ್ ಆಗಲ್ಲ. ಬಟ್ ನಿಮ್ಮ ಡಯಟ್ ಬರೀ ಕಂಪ್ಲೀಟ್ ಫ್ರೂಟ್ ಡಯಟ್ ಆಬ್ವಿಯಸ್ಲಿ ಆಗಿರಬಾರ್ದು. ಫ್ರೂಟ್ಸ್ ಬಗ್ಗೆ ಸುಮಾರು ಮಿಸ್ಕನ್ಸೆಪ್ಷನ್ ಇದೆ. ಫ್ರೂಟ್ಸ್ ಆರ್ ದ ಮೋಸ್ಟ್ ಹೆಲ್ತಿಯೆಸ್ಟ್ ಥಿಂಗ್ ಅಂತ. ಎಸ್, ದೇ ಆರ್ ಹೆಲ್ತಿ, ಇಲ್ಲ ಅಂತ ನಾನು ಹೇಳ್ತಿಲ್ಲ. ಫ್ರೂಟ್ಸ್ ಆರ್ ಹೆಲ್ತಿ, ಅದರಲ್ಲಿ ತುಂಬ ವೈಟಮಿನ್ಸ್ ಇರುತ್ತೆ, ತುಂಬ ಇದಿರುತ್ತೆ. ಬಟ್ ಆಬ್ವಿಯಸ್ಲಿ ಅದರಲ್ಲಿ ಶುಗರ್ಸು ಜಾಸ್ತಿ ಇರುತ್ತೆ. ಸೊ ಓನ್ಲಿ ಫ್ರೂಟ್ ಡಯಟ್ ಡೆಫಿನೆಟ್ಲಿ ಏನೇ ಆಗಲಿ ಬ್ಯಾಲೆನ್ಸ್ ಇರಬೇಕು. ಡಯಟ್ ಹ್ಯಾಸ್ ಟು ಬಿ ಬ್ಯಾಲೆನ್ಸ್ಡ್. ಪ್ರೋಟೀನ್ ಇಷ್ಟು ಅಂಶ ಇರಬೇಕು, ಕಾರ್ಬೋಹೈಡ್ರೇಟ್ಸ್ ಇಷ್ಟು ಅಂಶ ಇರಬೇಕು, ಫ್ಯಾಟ್ಸು ಎಸೆನ್ಷಿಯಲ್ ಫ್ಯಾಟ್ಸ್ ಬೇಕೇ ಬೇಕು ನಮಗೆ, ಫ್ಯಾಟ್ಸು ಬೇಕು ಅಷ್ಟು ಅಂಶ ಇರಬೇಕು, ವೈಟಮಿನ್ಸು ಮಿನರಲ್ಸು ಎಲ್ಲ ಬ್ಯಾಲೆನ್ಸ್ಡ್ ಆಗಿರಬೇಕು. ಎನಿಥಿಂಗ್ ಯು ಓವರ್ ಡೂ ಇಟ್ ಆಬ್ವಿಯಸ್ಲಿ ಇಟ್ ವಿಲ್ ಕಾಸ್ ಪ್ರಾಬ್ಲಮ್ಸ್.
Sir, nowadays a lot of young people, they are taking these artificial proteins, vitamins, minerals. What is the view about that? A general view about that?
Sir, first to just answer the other fruit thing is, I think it is best fruits are consumed au natural, which is as they come, because they will give you a balance of the fiber and the carbohydrates and everything that comes with it. If you have a fruit juice, pressed juice, you will only get the sugars and things, so the fiber is completely eliminated. So better to eat fruits rather than drink juice. I'm not saying you should not drink juice, but the healthier version is the fruit as it comes. And I think you want to take the protein supplements.
So protein supplements depends on the source of it. Lot of the source ಏನು ಅಂದರೆ ಸೋಯಾ ಬೇಸ್ಡ್ ಇರುತ್ತೆ, ಆಬ್ವಿಯಸ್ಲಿ ವೇ ಪ್ರೋಟೀನ್ಸ್ ಇರುತ್ತೆ. ಸೊ ಲಾಟ್ ಆಫ್ ದೀಸ್ ಒನ್ಸ್ ಅಗೇನ್ ಇಫ್ ಯು ಆರ್ ಏನಕ್ಕೆ ಬೇಕಾಗುತ್ತೆ ಅಂದರೆ ಅದು ಆಬ್ವಿಯಸ್ಲಿ ಅವರು ವರ್ಕೌಟ್ ಮಾಡ್ತಿರ್ತಾರೆ. ಒನ್ಸ್ ದೇ ಆರ್ ವರ್ಕಿಂಗ್ ಔಟ್ ಮಸಲ್ ಲಾಸ್ ಆಗುತ್ತೆ ಪ್ರೋಟೀನ್ ತೊಗೊಂಡಿಲ್ಲ ಅಂದರೆ. ಸೊ ಎನಫ್ ಪ್ರೋಟೀನ್ ತೊಗೊಳ್ಲೇಬೇಕು ಅವರು. ಆ ಥರ ವರ್ಕೌಟ್ ಮಾಡೋರಿಗೆ ಅಷ್ಟು ಕರಗಿಸ್ತೀರಾ ಅಂದರೆ ಅಷ್ಟು ತೊಗೊಂಡ್ರೆ ಪರವಾಗಿಲ್ಲ. ಬಟ್ ಅದು ಕರಗಿಸ್ದಂಗೆ ಬರೀ ಪ್ರೋಟೀನ್ ತೊಗೊಂಡ್ರೆ ಡೆಫಿನೆಟ್ಲಿ ತೊಂದರೆ ಆಗುತ್ತೆ, ಬಿಕಾಸ್ ದೆರ್ ಈಸ್ ಅ ಲಿಮಿಟ್ ವೇರ್ ಲಿವರ್ ಕ್ಯಾನ್ ಹ್ಯಾಂಡಲ್ ದಿಸ್. ಸಿಂಪಲ್ ಅಷ್ಟೇ ಸರ್, ಸಿಂಪಲ್. ಆಬ್ವಿಯಸ್ಲಿ ವರ್ಕೌಟ್ ಮಾಡಿ ಅದನ್ನು ಕ್ಯಾಲ್ಕುಲೇಟ್ ಮಾಡಬೇಕು. ಎಷ್ಟು ವರ್ಕೌಟ್ ಮಾಡ್ತೀರಾ, ಎಷ್ಟು ಇದು ಮಾಡ್ತೀರಾ ಅಂದಾಗ ಎಷ್ಟು ನಿಮಗೆ ಬಾಡಿ ಮಸಲ್ ಬಿಲ್ಡಿಂಗಿಗೆ ಎಷ್ಟು ಬೇಕಾಗುತ್ತೆ ಅನ್ನೋದ್ರ ಮೇಲೆ ತೊಗೋಬೇಕಾಗುತ್ತೆ. ಎಕ್ಸ್ಟ್ರಾ ಮಾಡಿದಾಗ ಲಿವರ್ ಫಂಕ್ಷನ್ ಟೆಸ್ಟ್ ಡಿರೇಂಜ್ ಆಗುತ್ತೆ, ಆವಾಗ ಡೆಫಿನೆಟ್ಲಿ ಪ್ರಾಬ್ಲಮ್ ಆಗುತ್ತೆ.
ಇನ್ನೊಂದೇನೆಂದರೆ ಇಟ್ ಶುಡ್ ಬಿ ಅಂಡರ್ ಸೂಪರ್ವಿಷನ್, ನಾಟ್ ಓವರ್ ದ ಕೌಂಟರ್. ಸಮ್ ಪ್ರೋಟೀನ್ಸ್ ವಿಚ್ ಕ್ಯಾನ್ ಬಿ ಕಂಟಾಮಿನೇಟೆಡ್ ವಿತ್ ಸ್ಟೆರಾಯ್ಡ್ಸ್ ತುಂಬ ಆಗುತ್ತೆ ಅದು. ಆ ಥರ ಆದಾಗ ಕಿಡ್ನಿ ಫೇಲ್ಯೂರ್ ಆಗೋದು ಆ ಥರದ್ದೆಲ್ಲ ತುಂಬ ನೋಡಿದ್ದೀವಿ ಯಂಗ್ಸ್ಟರ್ಸಲ್ಲಿ.
Sir, on an average, the general this one is that every gram of carbohydrate gives you 4 calories or 4 kilocalories, and every gram of protein gives you 4 kilocalories, and fat gives you 9 kilocalories. So the ideal diet should contain about 30 to 35% of carbohydrate, 30 to 35, 40% of fat, and the remaining 20-30% of protein. And the protein is generally utilized by the body not for calorific content, though it does give you calorie. It is used for the muscle building, body building, and then all the other repair mechanisms that happen, because there is constant repair. That is why a good 8 hours of sleep is required for the body to repair everything that you have damaged that day. So that is the reason for the sleep. So the proteins are generally not included in the calorific count, because it is mainly utilized for the bodybuilding. So that is to answer your question. As sir said, you only take as much excess as you have burnt, rather than trying to take too much. And all of these fat diets where you take only protein, and all of them have come and they have all gone. They have all fallen by the wayside. The ideal diet, what we use in India, is actually the ideal diet. I have been in England. I will tell you what we use in India. Actually, the Harvard University, they looked at everything, and to tell you, the idli, vade, sambar, chutney is the most balanced diet there is, because it will contain everything. So that is the thing. So, but as everything should be in moderation. Tuppa again is much maligned. Again, you can't have balla of tuppa. A small chamcha of tuppa may be useful.
God gives us body, maintains it, and gives the life, and He spoils the body. But at the same time, He will give the life. Whom to be considered as gods?
So that is a philosophical question rather than medical. See, if you believe in Shankaracharya's philosophy, you are the God, because aham brahmasmi. So you are, there is no this one.
ಸ್ನೇಹಿತರೆ, ನಾವು 2ನೇ ದಿವಸದ ಈ ಆರೋಗ್ಯದ ವಿಚಾರವಾಗಿ ತಿಳುವಳಿಕೆಯ ಅಭಿಯಾನಕ್ಕೆ ಬಂದಿದ್ದೇವೆ, ಮುಕ್ತಾಯದ ಹಂತದಲ್ಲಿದ್ದೇವೆ. ನಾಳೆ 3ನೇ ದಿವಸ ಹರ್ನಿಯಾ ಮತ್ತು ಅಪೆಂಡಿಕ್ಸ್ ಬಗ್ಗೆ ತಿಳಿಸಿಕೊಡಲು ಡಾಕ್ಟರ್ ಶಿವರಾಮ್, ಡಾಕ್ಟರ್ ವಿಕ್ರಮ್ ಎಸ್ ಬಿಳಿಗೇರಿ, ಡಾಕ್ಟರ್ ಹರೀಶ್, ಡಾಕ್ಟರ್ ದೇವಪ್ರಶಾಂತ್ ಆ್ಯಂಡ್ ಡಾಕ್ಟರ್ ನಿಶಾಂತ್ ಅವರು ಬರ್ತಾ ಇದ್ದಾರೆ. ತಾವು ಕೂಡ ಇನ್ನೂ ಹೆಚ್ಚಿನ ಸಂಖ್ಯೆಯಲ್ಲಿ ಬಂದು ಈ ಕಾರ್ಯಕ್ರಮದ ಪ್ರಯೋಜನ ಪಡೆಯಿರಿ. ಒಂದೇ ಒಂದು ಕಿವಿ ಮಾತು, ಪ್ರಶ್ನೆ ಕೇಳುವುದರಲ್ಲಿ ಉತ್ತರ ತಿಳ್ಕೊಂಡು ಪ್ರಶ್ನೆಯನ್ನು ಕೇಳುವುದರಲ್ಲಿ ಸರಿಯಲ್ಲ. ಪ್ರಾಮಾಣಿಕವಾದಿ ಸಂದೇಹ ಇದ್ದು ಡಾಕ್ಟರ್ ಹೇಳ್ತಕ್ಕಂತಹ ಸಲಹೆಯನ್ನು ಅನುಷ್ಠಾನಗೊಳಿಸಬೇಕು ಅನ್ನುವ ಇಚ್ಛೆ ಇದ್ದು ಅದರಂತೆ ನಡ್ಕೊಂಡ್ರೆ ಈ ಕ್ವಶನ್ ಆನ್ಸರು ಇನ್ನೂ ಹೆಚ್ಚು ಅರ್ಥಪೂರ್ಣವಾಗಿರುತ್ತೆ. ನನಗೆ ಗೊತ್ತಿರೋ ಉತ್ತರ ಅವ್ರಿಗೆ ಗೊತ್ತಿದೆಯಾ ಅನ್ನೋ ಪರೀಕ್ಷೆಯ ದೃಷ್ಟಿಯಿಂದ ನಾವು ಪ್ರಶ್ನೆ ಕೇಳಬಾರ್ದು. ಡಾಕ್ಟರ್ಸು ತುಂಬ ಶ್ರಮ ವಹಿಸಿ ಅವರು ಸಮಯ ನಮಗೆ ಕೊಡ್ತಿದ್ದಾರೆ ಪ್ರೀತಿಯಿಂದ. ನಾವು ಅಷ್ಟೇ ವಿನಯದಿಂದ ಅದನ್ನು ಸ್ವೀಕರಿಸಬೇಕು. ನಮ್ಮ ಕಡೆಯಿಂದ ನಾವು ಸೌಜನ್ಯಪೂರಿತವಾಗಿ ಅವರನ್ನು ಅಪ್ರೋಚ್ ಮಾಡಿದ್ರೆ ನಮಗೆ ಉಪಯುಕ್ತವಾದಂತಹ ಸಲಹೆ ಸಿಗ್ಬೋದು. ಒಂದು ಸೌಹಾರ್ದವಾದಂತಹ ಸಂಬಂಧವನ್ನು ಕೂಡ ನಾವು ಕಾಪಾಡ್ಕೋಬೇಕಾಗತ್ತೆ. ವೈಯಕ್ತಿಕ ಭೇಟಿ ಬೇರೆ, ಸಾಮೂಹಿಕ ಭೇಟಿಯಲ್ಲಿ ಈ ಒಂದು ಮನಸ್ಸಿನಲ್ಲಿ ಇಟ್ಕೊಂಡಿರಬೇಕಾಗತ್ತೆ. ಇದು ನನ್ನ ಮನವಿ. ಸಂಸ್ಥೆಯನ್ನು ಪ್ರತಿನಿಧಿಸಿ ಮಾತನಾಡ್ತಿರೋದ್ರಿಂದ ಸಂಸ್ಥೆಯ ಗೌರವಕ್ಕೂ ಕೂಡ ಕುಂದು ಬಾರದ ರೀತಿಯಲ್ಲಿ ನಮ್ಮ ನಡವಳಿಕೆ ಇರಬೇಕಾಗತ್ತೆ. ಇಷ್ಟು ಹೇಳಿ ಇಂದಿನ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ನಡೆಸಿಕೊಟ್ಟಂತಹ ಡಾಕ್ಟರ್ ರವಿಶಂಕರ್, ಡಾಕ್ಟರ್ ನಿರಂಜನ್, ಡಾಕ್ಟರ್ ರಾಘವೇಂದ್ರ ಬಾಬು ಇವರೆಲ್ಲರಿಗೂ ಕೂಡ ಸಂಸ್ಥೆಯ ಪರವಾಗಿ ತಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಹೃತ್ಪೂರ್ವಕ ಕೃತಜ್ಞತೆಗಳನ್ನು ಸಲ್ಲಿಸ್ತಾ ಇದ್ದೇನೆ. ನಮಸ್ಕಾರ.